We are live.
Good evening. Welcome to GuruSangam, which is our teachers education program or teachers teaching program, as we call it, with the aim of education, elevation, and excellence. So basically, we encourage teachers to teach on this forum so that the best of teaching talents can be brought out all across the country. And finally, of course, we'll have a teachers conclave sometime in February in Delhi and have all these teachers present the best of their works. So today we have the session which is exclusively for pediatric ophthalmology and strabismus and also refraction and refractive errors. Our chairman today is Dr. Santan Gopal. This was the presidential initiative of Dr. Harbans Lal. Dr. Gopal is past president of AIOS and heads Kamal Netralaya Bangalore and has special focus on strabismus. It's very close to his heart, strabismus and amblyopia, and continues to teach with passion. We have our moderators, Dr. Manjushri Bhate, who is a consultant ophthalmologist in pediatric ophthalmology and strabismus service at LV Prasad Eye Institute, Hyderabad, and Dr. Jitendra Jethani, who is the director of Baroda Hospital, and he's a squint specialist and has special focus on pediatric ophthalmology as well. So I invite Manju and Jitendra to chair the session, moderate the session, and introduce the first speaker as well.
Thank you so much, Santosh, and welcome everybody. And I hope this is a great learning session, and it's a great initiative by All India Ophthalmic Society. So thank you for putting it together. We'll start straight away with the session, and I'd like to introduce the first speaker for today, who is Dr. Annapurna Kumar. She's currently the PG teacher at Arvind Eye Hospital in Pondicherry and did her MBBS and MS in Bangalore and Mysore. And she has the AP's Ophthalmology Pearls with more than 25,000 subscribers. So over to you, Dr. Annapurna. Can you please share your screen? Yeah, we can see your screen.
Okay, shall I start?
Yes, please.
Okay, so good evening, everybody. And first of all, I'd like to thank AIOS for this opportunity. Sensory tests in strabismus are basically for evaluating the various adaptations that occur as a result of strabismus. And ideally, sensory testing has to be done prior to all other testing in strabismus, basically because when you do either prolonged occlusion or dissociation of the eyes, certain unwanted features do come out, and these do not represent what occurs in conditions of daily living. And that is why ideally the sensory tests have to be done first whenever you evaluate a patient with strabismus. And most of these tests evaluate diplopia, whether it's crossed or uncrossed, the presence or absence of suppression, presence or either normal or anomalous retinal correspondence. And some of the tests can even pick up the special features of the monofixation syndrome. So before starting the test, a very small, brief orientation. The image of an object falls on the fovea of both eyes. And in that situation, the object is seen singly as a result of binocular fusion. When there is a strabismus, the image falls on a non-corresponding point of the deviated eye. And if there is a normal retinal correspondence, this is projected to a different place in space, not the forward position, and therefore there will be diplopia. Now, in a normal retinal correspondence, in the presence of an exotropia, as seen in this case, there will be a cross diplopia, and vice versa in esotropia. In esotropia, you get an uncrossed diplopia. Now, if you optically correct this deviation with a prism, then in the deviated eye, the image will fall on the true fovea, and then the object will be seen singly. Now, let's see what happens in anomalous retinal correspondence. Now, this pseudofovea now has the straight ahead position, and the object will be seen singly. If you correct prismatically the deviation in an ARC, technically the image is falling on the fovea, but now this is perceived as being, in this case of exotropia, for example, it is perceived as being nasal to the straight ahead position, and therefore this is projected temporally, and you get an uncrossed diplopia. So this is called paradoxical diplopia. So in a case of ARC with exotropia, you get an uncrossed diplopia, and in esotropia, you get a crossed diplopia. That is in ARC. Now, if you surgically correct an exotropia, okay, in the presence of an ARC. Again, technically the image has fallen on the fovea, but this is now nasal to the straight ahead position. Again, there is a paradoxical diplopia. However, this paradoxical diplopia that occurs after surgery is usually temporary and usually resolves within a couple of days to weeks. So these are the various tests that I will be discussing today. Ideally, even the stereo acuity tests are very important, but today, because of lack of time, I will be, and these are the ones which are a little more confusing. I will be discussing only these tests. Now, first coming to the Bagolini striated glasses, these are very similar to the Maddox rod in the sense that they convert a point source of light into a straight line. They are different in all other ways. They are less dissociating. Now, when you see through a Maddox rod, it's a series of prisms. You don't even see the central fixation light. All you see is the streak of light. However, Bagolini striated glass has only striations, and in between the striations, there is a plain glass. So it is less, in fact, it is the least dissociating of all the sensory tests, and it is the most preferred because it is the least dissociating. It simulates the conditions of everyday living and therefore tells you how best the patient is adapting to the strabismus. It permits near normal viewing, it permits fusion, it permits accommodation, and you can even do the cover test with the Bagolini lenses. Now, how do you orient these lenses? Now, this is from the patient's point of view. So, obviously, the right eye is on the right. You place the striations of the Bagolini lens at 135 degrees from the patient's point of view in front of the right eye, 45 degrees in front of the left eye. Or in other words, the striations are placed upwards and inwards. The streak of light is seen perpendicular to the striations, and therefore in the right eye you see it this way, in the left eye you see in this way. And when both eyes fuse, this is what a normal person sees. See, because this is almost conditions of near normal fusion, the central light can be seen, and the images from the two eyes which cross each other perpendicularly exactly in the center. Now, what exactly do we assess? One, first look, what is the type of tropia that is present? How many lights are there? If there are two lights, it indicates diplopia. How many lines are there? Only one line indicates suppression. What is the position of lines with respect to each other? Are there any gaps in the lines? Gaps indicate suppression scotomas. So these are the various things we will see. Now, scenario one, this is what the patient sees. On cover testing, there is an ocular deviation. So essentially, this is what a normal person sees. But in the presence of atropia, this indicates an anomalous retinal correspondence. So when you see this, if there is an if there is no deviation, it indicates normal retinal correspondence. And if there is a deviation, it indicates an anomalous retinal correspondence. Now, scenario two, this is what the patient sees. So let us go to each one of these one by one. Is there diplopia? No. Suppression? Yes. The right image from the right eye is not seen. Cover test shows a right tropia, and this is a case of right suppression. The type of tropia doesn't matter. That anyway your cover test would have decided. Scenario 3, this is what the patient sees. Now this looks a little confusing. Answer each one of these and you know what it is. So diplopia, no. Suppression, there is no gross suppression, but in the image seen by the right eye, there is a small gap in the center. This is classic for a central foveal suppression scotoma, and this picture is classical for a monofixation syndrome, in which there is a unilateral absolute central facultative scotoma peripheral fusion, and a small angle tropia which may or may not be present. So if you see this picture, there may or may not be a small tropia, but regardless, this picture is characteristic of monofixation syndrome. Scenario 4, if a patient sees this, let's answer our questions again. Diplopia, yes, because you're seeing two central lights. The image, the right-sided light belongs to the image in the right eye. So this is an uncrossed diplopia. And if your cover test shows an esotropia, this is evidence of normal retinal correspondence. Scenario 5. If you see this, again, diplopia, yes. What type of diplopia is it? You can see that the light on the right belongs to image on the left. This is a cross diplopia. And in the presence of an exotropia, it indicates a normal retinal correspondence. Sometimes the images may be further apart if the deviation is greater, or you may even see a vertical separation. Now let's come to the Worth 4 dot test. Now all of you are aware of the orientation of one red, two green, and one white light. These are seen with red-green glasses. If you have Armstrong goggles, they are preferable because they closely they are close to the orbital margins, and therefore they prevent the person from seeing around them. And this is usually available in the vision drum. For near, by the way, I forgot to mention that most of these tests have to be performed with the refractive correction in place and for both distance and near. For the near Worth 4 dot test, the Worth 4 dot flashlight may be used. Yes. So if a person sees this and the cover test shows orthophoria, this is normal because we wear the red-green glasses with the red in front of the right eye, the green in front of the left eye by convention. So the right eye sees the red, the left eye sees the two greens, and the white light will depend on which eye is dominant. If the right eye is dominant, it will appear red. If the green eye is dominant, it appears green. If both are of equal dominance, you see sort of green and red alternating. So this is normal. Now, if you see a similar picture in the presence of atropia, it indicates anomalous retinal correspondence. Now, what do we see here? We see only the image seen by the right eye. Therefore, there is a left suppression. And of course, here we are seeing only the images from the left eye. So this indicates a right suppression. Now, here the images from the right eye and the left eye are separated. 5 circles are seen. This indicates diplopia. And the image from the right eye, as you can see, is on the right side. So this is an uncrossed diplopia. And in the presence of esotropia, indicates a normal retinal correspondence. Here you can see there's a cross diplopia. In the presence of an exotropia, it again indicates a normal retinal correspondence. Now, probably the most important or rather valuable test for the Worth 4 dot is the monofixation syndrome. For the monofixation syndrome, for both distant and near, the Worth 4 dot flashlight is to be used. So when the flashlight is used from 3 meters or more, what happens is it falls within the foveal suppression scotoma of the eye, which has the suppression scotoma, and therefore it's equal to suppression, which means what will the patient see? The eye with the foveal suppression scotoma will not see anything. The other eye, that is the fixing eye, if it is the right eye, you see red dots. If it is the left eye, you see only green dots. Now, bring the Worth 4 dot flashlight to within 2/3 to 1 meter. Now, at this distance, the lights fall outside the foveal suppression scotoma, and the person sees what a normal person sees. Now, let's come to the red glass test. In a strabismic patient, okay, the red glass is placed before the fixing eye. The patient views a distant white light which stimulates the fovea of the fixing eye and an extrafoveal area of the fellow eye. Remember, the red glass is in front of the fixing eye. And in all the following examples, The left eye is the fixing eye. Therefore, I've placed the red glass in front of the left eye. The eye without the red filter sees the white light as white. The eye with the red filter sees it as red. And if there's a fusion response, if both eyes are seeing together, it appears slightly pinkish or sometimes a washed out red appearance. Here I'm showing everything as pink, so it becomes easy. So again, we answer these same questions. Left eye is the fixing eye. So in a right esotropia, if we see this, is there diplopia? No. Is there suppression? No. So in a esotropia, we are seeing what appears to be a fusion response. This indicates the anomalous retinal correspondence. That is because here the pseudofovea has shown the straight ahead position. Scenario 2. This is what the patient sees. Let's answer our questions. Diplopia, yes. Crossed or uncrossed? The image from the left eye is seen on the left. This is an uncrossed diplopia. And in the presence of an esotropia, this indicates normal retinal correspondence with absence of suppression. Now let's come to scenario 3. Here we are seeing a cross diplopia. And in the presence of an exotropia, it indicates a normal retinal correspondence again. Scenario 4. This is what the patient sees. Is there diplopia? No. Suppression? Yes, we are not seeing the image. It appears only red. There is no pinkish or anything. Okay. And this is an evidence of suppression. The type of tropia, regardless of whether it's ESO or EXO, if it's suppression, the image from the non-deviated eye will not be seen. Now let's come to scenario 5. We have a suppression. So you don't know whether this is a case of normal or anomalous retinal correspondence. How do we determine that? We need to bring the image from the deviated eye out of the suppression scotoma. How to do that? We place a vertical prism in front of the deviated eye. Now here I have placed a base up prism, which means the image will be directed towards the apex. That is, the image in the deviated eye will be below that of the eye from the fixing eye. So regardless of the type of correspondence, the images in the two eyes will be vertically separated. Horizontal separation or not will determine the type of correspondence. So if there is a horizontal separation in addition to a vertical separation, this indicates a normal retinal correspondence. And if both are right, one above the other, it indicates an ARC. This is because in ARC, the pseudofovea projects straight ahead. So we have the straight ahead projection, though vertical separation is because of the prism. Scenario 6. Now, in a right esotropia, if we optically correct the prism, see esotropia, we use a base out prism, you see what appears to be a fusion response. This is a normal retinal correspondence because now what is happening is the image is falling on the true fovea, everything is fine. So this is a normal retinal correspondence without any suppression. Scenario 7. Now let us say the patient has an esotropia, you have used a base out prism, you have optically corrected the deviation, but the patient is having now a diplopia. Not only is the patient having a diplopia, patient has an esotropia, and here we are seeing a cross diplopia. This is characteristic of, this is a paradoxical diplopia, and it is characteristic of an anomalous retinal correspondence. Again, because the image falls on, even though it falls on the true fovea, it appears temporal to the straight ahead position. Therefore, there is a cross diplopia. Now, the red glass test is a little difficult for children to appreciate because it's not easy for them to correctly tell you what is what. So its greatest use is in adults. Either for adults who complain of diplopia, but grossly they appear to be orthophoric, or during prism fitting. Now, the 4 prism diopter base out test is used exclusively in monofixation syndrome. It is to determine the presence of the central facultative scotoma that is present in the monofixation syndrome in the absence of a manifest deviation. To recollect, monofixation syndrome is a unilateral central facultative scotoma, peripheral fusion, plus or minus tropia. So if there's a tropia, there is no problem. But in the absence of a manifest deviation, sometimes you see a child, vision is diminished, you're not sure why there is no deviation, then you would like to know if the patient has a monofixation. This test is performed during binocular viewing because remember, there's a facultative scotoma, which means it is only present when both eyes are open. It is performed with the the prism first in front of one eye and then the other. So in order to know what is abnormal, first we need to know what is normal. So in a normal person with bifoveal fixation, if you place the base out prism of 4 prism diopters in front of one eye, now what happens is, whenever you place a prism in front of one eye, the image is deviated towards the apex. So what will happen? The eye behind the prism will move towards the apex in order to fix that. Once this does that, the eye without the prism will also move in the same direction due to Hering's law. Therefore, there is an initial version movement towards the apex of the prism. Okay. Now, once this happens, temporarily, this eye will experience diplopia because it has moved. So what will happen? A nasal refixation vergence will take place to maintain fusion. Okay. Regardless of, if in a normal person, regardless of in front of which eye you place the prism, you see the same. Now let us see what it looks like. So I've placed the prism, notice the version, and now the refixation vergence. Now let's place it in front of the other eye. Okay, see the version, see the refixation vergence. Okay, that is normal. Now let's see what happens in monofixation with foveal scotoma in the left eye. Okay, right. Now we are placing the prism over the fixing eye. This doesn't have the suppression scotoma. So what happens? Again, because the image is moved towards the apex, this eye will move nasally. Because of Hering's law, this will also move. So the initial version towards the apex takes place. But now what happens is, this eye has moved, but the image, since the movement is very small, the new image is still within the foveal suppression scotoma, which cannot be perceived, and therefore the refixation vergence does not take place. Let's see what it looks like. I place in front of fixing eye. You can see only the version. There is no vergence. Now, when you place in front of the non-fixing eye, what happens is, the image is displaced again towards the apex, but this displacement is so small, it is within the foveal suppression scotoma. So the eye behind the prism does not move. The other eye, therefore, obviously will not move. Ultimately, when you place the prism over the non-fixing eye, no movement takes place. Okay. So to summarize this test, in a monofixation, when you place the prism in front of the fixing eye, only the version movement is present. And when you place it in front of the non-fixing eye, no movement takes place. Now, coming to the last test, the after image test of Bielschowski. This is different in that from the other test in that it's not for monofixation, it's not for diplopia, it doesn't pick up suppression. It has only one function, to determine whether there is normal retinal correspondence or anomalous retinal correspondence. It is the most dissociating of the tests. It doesn't work in eccentric fixation, and it's most useful. And so again, children find it very difficult unless they're very mature. But it's mostly useful in adults with long-standing intermittent exotropia. So if you want to do a surgical correction, it might be useful to do this test to determine if there's NRC or ARC. So what you do is, you stimulate the fovea of each eye in turn with a strobe light. A strobe light is a high intensity flashing beam of light. And you can either use a camera flash. You can, mask the rest of the light so that just either a vertical or a horizontal streak is seen. and the center of the light should be masked. For what purpose? One, to protect the fovea and to serve as a fixation point for the eye. Now, how do you do this test? First of all, exclude eccentric fixation, close the deviated eye, stimulate the fixing eye with a horizontal light streak. 10 or 20 seconds. Some books say 10, some say 20, so that's fine. The deviated eye is stimulated with a vertical streak of light and then ask the person what she sees. Now, you can either do this in a dark room, or patient can be asked to close his eyes, in which case you see bright after images. These are called positive after images. Or you can use it in the bright light, in which case the after images are seen as dark lines and these are negative after images. Either is okay. Now, in each of these scenarios, if you remember, the fixing eye is stimulated with the horizontal streak of light and the deviated eye with the vertical. So first, let us see the first scenario. Always there will be a gap in the center, because remember, we have masked the fovea of the strobe light. Therefore, a gap will be seen in the center. Now, if you see this, a central gap with both the horizontal line from the one eye and the vertical line from the other eye exactly crossing perpendicular, this indicates a normal retinal correspondence regardless of whether there is a deviation or not. Remember, we performed this test monocularly. So we closed one eye. So one eye fixes, we close the other eye fixes. So we make sure that only the fovea is stimulated in each eye. Therefore, regardless of whether there's a deviation, regardless of in which direction the patient is looking, regardless of whether the patient is converging or keeps moving the eyes back and forth, this is what you will see if there is a normal retinal correspondence. Anything other than this indicates ARC. For example, take this. Here, there is an esotropia with ARC. What will you see? You will see this. Here, what has happened is the after image from the left eye is seen on the right, and the after image from the right eye is seen on the left. So we get crossed after images. Why is this so? This is the pseudofovea. This is the straight ahead position. But since we stimulated the fovea, this is perceived as being temporal to that of the straight ahead position. Therefore, it is projected nasally. So you get crossed after images. On the other hand, in a case of exotropia with ARC, you get uncrossed after images. Again, the explanation, the pseudofovea is straight ahead position. The fovea which has been stimulated in an exotropia lies nasal to the straight ahead position. So it is projected temporally. So you get, what is this? Uncrossed after images. So this completes the tests of, like I said, I have not talked about stereo acuity tests. These complete the other sensory tests in strabismus. Thank you.
Thank you very much, Dr. Annapurna. That was a very simple but understandable illustration of the sensory science in strabismus. We have used only diplopia part. In ARC, what I am seeing is the central part is closed. The peripheral parts or the non-foveal or extrafoveal parts of the retina will still have normal correspondence if it is esotropia. So, what you are saying basically is the correspondence of the peripheral and central retina. Both are abnormal in ARC, which may not always happen in clinical
practice. May not always. Yes, sir. That's right. That's right.
Happen in clinical practice.
Yes, sometimes different parts can have different types of correspondence. That's right. Correct.
So, if there are many others listening, what I would suggest is ask simple questions. Is the image crossed eye image will be on the uncrossed. If the eyes don't cross, the image will be crossed. It's as simple as that. The second important thing is when you do in cases of monofixation syndrome, I've tried this before. No matter which direction you keep the prism, the eye does not move. You said you keep the prism with the apex inside. Eye shouldn't move if it is a normal correspondence. If it is ARC, the eye will not move. So I tried it. Put any eye in any prism in any direction in front of the monofixation syndrome, the eye does not move. But because the scotoma prevents the size of the scotoma is more than 4 prisms. So you are using only 4 prisms. If you put 8 prisms or maybe 10 prisms, it will move. You understand? 4 prisms you can put whichever direction, the eye will not move. But if you put 8 prisms and move, the eye moves. So on simple modification to it. I think I request all the other speakers to follow the pattern of Dr. Annapurna. Stick to your time and finish in 30 minutes so that we have some time for discussion. Who is the next person? Dr. Manju, you can introduce the next speaker.
Dr. Chaitani will introduce the next speaker. So thank you, Dr. Annapurna. I think that was very clear and it was very useful as well, the way you simplified each of the subheadings in your talk. So I'll hand over to Dr. Chaitani to introduce the next speaker.
Can we have the slide for introduction of Dr. Arvind Kumar? Okay, Dr. Arvind Kumar Maurya, we all know he is head of the department in Department of Ophthalmology, AIMS, Hyderabad. And he will be speaking on, he just last year, he received the Best Paper Award for, ICL. I think there is a publication also by them in IGO on ICL implantation for amblyopic children, and they have got wonderful results with minimal complications. And the topic is amblyopia and newer modalities of management. So, Dr. Arvind, you can share your screen.
Thank you, sir. Is it visible?
Sir. Yes, sir. Please go ahead.
Okay. So good evening, respected chairpersons, esteemed panelists, and my dear colleagues. So thank you, AIOS, for giving me the opportunity to make this, make me a part of this prestigious AIOS GuruSangam. So today I will be speaking on amblyopia and the newer modalities for its management. And I thanks to all the innovators in India who has done a lot of work in the management of amblyopia. So there are a lot of definitions of amblyopia. So for the first definition, that it is a neurodevelopmental ocular disease manifested as monocular and binocular impairments, including vision reduction, contrast sensitivity, or even loss of stereoscopic vision. The other definition says that it is the unilateral or less commonly bilateral reduction in best corrected visual acuity that cannot be attributed directly to the effect of any structural abnormality of the eye or the posterior visual pathway. And at least difference of 2 lines needs to be there in logMAR chart. The other definition is that it is a visual disorder because of the failure of cortical visual development in one or both eyes because of ocular pathology earlier in life. Consequences of amblyopia include poor stereo vision, visual acuity, pattern recognition, and low sensitivity to motion and contrast. So does we need to follow the old Neanderthal definition, or we need to follow the female, the alpha female James Bond definition? So it definitely requires redefining. There are lots of factors to be reconsidered. So we need to redefine amblyopia, excluding all other causes for visual acuity reduction, the cerebral changes defined by the functional blood oxygen level dependent MRI, methods of management, and combination of treating modalities. The other factors are eye-brain ability to process motion, shape perception, spatial interaction, hyperacuity, contour integration, and the binocular single vision components. So why this amblyopia is a matter of concern? Because of this national status. There is ignorance and cost related because the management is costly. The incidence and prevalence of refractive amblyopia are very high among the school-going children. The isometropic, isomyopic, and anisohypermetropic amblyopia, and the stereoacuity is affected in refractive amblyopia, so there is no binocular single vision. And this also affects the amblyopic patients from getting jobs such as in the Navy, Air Force, and commercial pilots. There are psychosocial issues faced by the children like bullying and harassment associated with glass use, especially if these are thicker and associated with higher refractive errors. And in India, there is no complete ocular examination at the time of admission in the schools, and this leads to undetected and untreated amblyopia in this age group. Also, the teachers as well as parents are often ignorant about the gravity of this ocular condition. Therefore, there is a strong need for alternative treatment strategies to manage pediatric and adolescent patients with amblyopia. Regarding the epidemiology, in developing nation, up to 5%. In India, it is up to 4%. And it is more commonly seen from the birth to the 7 years of age. And earlier the onset, greater is the deficit. And it is 4 times more common in the premature children age group and 6 times more common in children with delayed milestones and mothers on drugs and alcohol. There is also a risk of amblyopia. So we need to look at the pathophysiology. So there are amblyogenic factors, role of retina is there, and active cortical inhibition. So first, the amblyogenic factors, which are visual deprivation, which can be monoocular or binocular, seen in bilateral cataract, or it can be because of the light deprivation, seen in children with unilateral or bilateral complete cataracts. And of course, abnormal binocular interaction seen in strabismus, anisometropic and unilateral stimulus deprivation, amblyopia. And there is role of retina also. So there is decreased sensitivity of foveal cones in amblyopia, and decreased inputs from rods and cones from the affected eye leads to neurophysiological changes which are transmitted to the central nervous system, leading to amblyopia. Then comes the active cortical inhibition, so visual pathway. So the developmental defect, they leads to problem with the spatial visual processing and poor transmission from the fovea and optic nerve to the striate cortex of the affected eye, and the abnormal development of the lateral geniculate body and the striate cortex. The ganglion cells in the foveal area are also affected. In the amblyopic eyes, there is shrinkage of the LGB nucleus and striate cortical fibers, and these LGB and striate cortex, they lead to loss of binocularity driven cells. So this is the brief classification of amblyopia. It can be strabismic, refractive, it can be anisometropic or isometropic, and deprivational because of the eyelid abnormalities, corneal abnormalities, lenticular abnormalities, and occlusion or reverse amblyopia from excessive patching. So first we will go with the anisometropic amblyopia. It is the second most common cause of amblyopia. So there are unequal refractive errors in the 2 eyes, causing image on one retina to be defocused chronically, and there is no misalignment detected on visual assessment. Hypermetropic anisometropia is more amblyogenic than the myopic anisometropia. The amount of anisometropia is hypermetropia of more than 2 diopter, myopia more than 4 diopter, astigmatism more than 1.25 diopter, and unilateral high hyperopia or myopia of more than 6 diopter leads to severe amblyopia. Meridional amblyopia, that is uncorrected astigmatism, leads to reduced resolution of eye in selective meridians, that is more than 1.5 diopter cylinder causes amblyopia, and it develops after 1 year of age. Then comes the isometropic amblyopia. These are high uncorrected refractive errors, hyperopia of more than 5 diopter, myopia of more than 10 diopter, astigmatism of more than 2 diopter, and mechanism is because of the blurred retinal image in both the eyes. So how to clinically evaluate these cases of amblyopia? So clinical history is very important. Binocular red reflex, as you can see in the first picture, it is normal in both the eyes. In the second picture, it is normal in right eye. Left eye, there is no red reflex. And again in the third, the right eye is normal, whereas the reflex is yellow as seen in the other eye. Then need to go for the stereo acuity testing, visual acuity and ocular mortality, external examination, pupillary examination, complete ocular examination, along with fundus examination. Cycloplegic retinoscopy is required, and neutral density filter and crowding phenomena can also be tested. So visual acuity, difference of two lines on log mark, bilateral amblyopia, it will be, the difference will be 20/40. The infants, we need to see the fixation pattern, and the pre-verbal children, we can go for preferential looking test, the visual equate potential, as well as the optokinetic nystagmus test. In the age group 2 to 3 years, we can go for E-chart and pictorial chart, and more than 3 years, Snellen, Logmar, HOTV, these are very useful. Stereo acuity can be tested using Titmus fly, random dot toss, and I prefer two pencil tests. This is the Lang's pencil test. So what we can do horizontal as well as vertical. We can see whether the patient is able to align the two pencils. It's a very simple test and can be easily done. Fixation reflex it is done in the less than 5-year age group. So we need to see for the central steady and maintained fixation. It shows good visual acuity. A fixation, that means visual acuity is less than 3/60. Unsteady fixation means the vision is 3/60 to 6/60. Central but ill-sustained, that means the vision is 6/60 to 6/18. It is central but a strong preference for other eye. That means the vision is 6/18 to 6/9. If the fixation is alternate and good, that means the vision is 6/6. Crowding phenomena, so better visual acuity with single optotype, and single optotype line acuity improves more than the multiple optotype line or treatment. So both needs to be recorded. It is a prognostic indicator also. Neutral density filter, it reduces the overall luminance without inducing a color change. And there is decreased luminance of visual targets, result in diminished central acuity in the normal eye. No effect on anisometropic amblyopia. Reduced vision in cases of organic amblyopia when there is optic nerve hypoplasia and these colobomas. Strabismic amblyopia, there will be improvement. The other findings will be in VAP, reduction in amplitude and prolonged latency. Afferent pupillary defect can be there. Visual acuity normal in dim light, and latent nystagmus can also be there. So these are the traditional methods. Now I am coming to the management part. So there is the gold standard was conventional occlusion therapy, but there is high rate of recurrence of up to 50%. Penalization also has loss of accommodation and reverse amblyopia. Contact lenses, although a good modality, but they are very thick and poor patient compliance. So what is new? The future is really bright. So first is the keratorefractive procedures. So these laser refractive methods such as photorefractive keratectomy, laser keratomylosis have emerged as alternate corneal refractive surgery techniques which are effective as well as safe in children and young adults who are not compliant with the conventional approaches. But there are complications such as corneal haze in PRK and flap-related complications in LASIK along with keratosis and corneal thinning. As they are expensive, all the patients cannot afford this surgical modality. Also, we cannot use this treatment modality in younger children as been approved in the European and the US countries. So we did a world first clinical trial on phakic IOL versus occlusive versus orthoptic magnocellular stimulator. So phakic IOL is one more method for correction of refractive amblyopia in children and young adolescents. It has advantages such as reversibility and ability to exchange IOL, predictability, high visual acuity, and preservation of accommodation. But there are complications associated such as cataract, glaucoma, retinal detachment, endothelial cell loss, dislocation, pigment dispersion, and shallow anterior chamber can be encountered, but not seen in any of our clinical trial cases. But it was done for only 1.5 years, so more follow-ups are needed to assess the complication and safety in long-term period. So these were the results of our study. So pre-operative, the uncorrected distant visual acuity improved from 1.39 to 0.11 with a significant p-value. Gain in visual acuity lines from the uncorrected visual acuity, it was 12.1, and best corrected visual acuity Again, the lines improved were 2.6 with significant p-value. Contrast sensitivity also improved from 1.07 to 1.66 with significant p-value. And as we compared IOP, there was no difference. And the endothelial cell count loss as the last visit was only 5.78%. And as we compared the stereo acuity, so it took most time in improvement. So it also increased from more than 800 millisecond arc to 150 with a significant p-value. Then comes the Occlutab. It is a modified electronic device for amblyopia treatment. It involves the use of specially designed binoculars with a modified common tablet device. So by playing games on the tablet with a tangible cube, the child is made to improve hand and eye coordination with the affected LAGI or the amblyopic eye as seen in the picture. So the wide screen technology, it eliminates the side effects of conventional eye patches and enhances stimulation of the visual field by selectively presenting images to one eye while both eyes are open. So it trains the brain to perceive the suppressed inputs from the LAGI or the amblyopic eye and eventually leads to a balanced, unanimous binocular vision. But there is a chance of recurrence after a few days of completion of treatment. So in India, the first study was done by Dr. Sulabh Sao in 2018. So the best corrected visual acuity improved from 0.5 to 0.3 in the Occlutab group, and in the occlusion group, it was from 0.56 to 0.38. The contrast sensitivity also increased to 1.75. Stereo acuity also improved to 100, whereas in the occlusion group, it was not much with 125 millisecond of arc, and contrast sensitivity also able to increase up to 1.2. Then comes the Binox. It is a uniquely designed cloud-based software developed by LVPI for lazy eye treatment, and it solves these problems by offering an AI-based binocular vision therapy that shows results in 6 weeks with only a laptop and specialized anaglyph glasses. And it costs approximately 12,000 rupees for each patient, but on an average 45 sitting of half an hour to 1 hour is required. So sometimes there is poor patient compliance. And now comes the most novel treatment, that is the Orthoptech magnocellular stimulator. It is the most economical device and the best option for treatment of amblyopia as per our experience. It aims to exercise parts of the amblyopic patient's brain by stimulating the parvocellular and magnocellular pathways to gradually improve not just the monocular vision of the amblyopic eye, but also helps to improve the stereoptic vision, thereby bringing about a noticeable improvement in both their quality of vision and quality of life. Other indications, there are 12 ocular indications. So it can be done in 6 nerve palsy, partial third nerve palsy, Alzheimer's disease, hyperactive children, attention deficit disorder, but studies needs to be done in these fields. It has the early recovery and patient needs to carry only a laser torch while doing this exercise. So this OSM has the early recovery time compared to other treatment modalities of amblyopia. So what is the hypothesis behind it? So the top-down impulses originating in the prefrontal cortex and alter the attention mechanism, which in turn affects the striate cortex. The peripheral stimulus makes the eye to move to ensure foveal fixation. This is called as overt attention. When the patient is fixating on the central light and still can see the peripheral lights, it is known as covert attention. So both the covert attention and the overt attention, they stimulate the lateral occipital cortex via the top-down impulses. And these are the motor and sensory aspects of vision that are used for the development of Orthoptech magnocellular stimulator. So this is how there is a dichomatous pathway carrying the visual signals. So from the retina, magnocellular, these are from the peripheral area, parvocellular cells, these are containing the central area. So they goes to lateral geniculate body, ventral part, the magnocellular cells, they discharge in the first and second ventral part. And whereas the parvocellular, they discharge in the 3, 4, 5, and 6 area, dorsal areas of the LGN. The parvocellular, so they go and discharge in the layer 4C beta in the V1 area of the occipital cortex, that is the inferotemporal cortex, that is what of vision. And magnocellular, they goes into the layer 4C alpha in the V1 area, that is, it goes into superior parietal cortex, that is where of vision. So when we, the patient see with the help of the laser torch. So there is a screen and the lights are coming and going with a difference of 300 to 500 milliseconds. So there is a sudden appearance of the light that stimulates the saccadic movement, is associated with the stimulation of the fovea in V1 area via top-down impulses. So there is suppression of the retinal area between the fovea and the peripherally stimulated retinal points to avoid smearing effects. So these repeated stimulation of the magnocellular cells via the attention area in the parietal cortex leads to stimulation of fovea. And these prosaccades are associated with maximal stimulation of the V1 area. So how it is done? The OMS device has 3 rows of LED of the central red light and the others are white. And the patient is made to sit at 1 millimeter distance. The patient is instructed to quickly point at the light that switches on and off using a laser pointer. The patient needs to be quick and should not miss any of the light. And each time the light is on for 300 to 500 milliseconds, which may be difficult for the deeply amblyopic patient during the initial session or 2. So this is how it is done. First done for the amblyopic eye with the good eye passed for 20 minutes and repeated with the good eye open and amblyopic eye passed for 5 minutes. The process is then repeated with both eyes open for 5 minutes. This stimulates the overt attention center in the brain, which in turn stimulates the lateral occipital cortex. Then the patient is instructed to focus on the central red light and without changing gaze, count the peripheral lights that switch on about 300 times. And these are the tests which are done pre and post treatment. So there is definitely a role of functional blood oxygen level dependent MRI. So the normal population, as seen in the upper picture, having binocular single vision, have proper blood supply and oxygenation in the occipital, frontal and parietal lobes. But as seen in the next picture, in the amblyopic patients, it is reduced substantially in these lobes. So we have observed pre and post treatment changes in the functional bold MRI in these patients. So this was one of a very 56-year-old patient. This is how it is done. So he is following the light with the help of the laser torch. So right now there is only one study by Dr. Santhan Gopal. So there was improvement in the stereopsis with a significant p-value from 300 more than 300 seconds of arc to 153 to 500 millisecond of arc. The binocular single vision also improved. It was only one pre-treatment, but that improves to 91%, that is in the 32 patients. The visual acuity also improves from 0.3 log mark to 0.07 plus minus 0.1 with a significant p-value. Also, the eyes also become orthotropic in 26 out of 33 eyes. So it has also shown significant improvement in vision, stereopsis, improvement in hand-eye coordination, improved self-confidence, that is most important, reduced nystagmus and strabismus. So I'm sharing one case which we treated at our center. So this was a 56-year-old, right eye amblyopic plus 2.5, 618 and left eye minus 1 diopter, 6/6. Contrast sensitivity was 0.35 and stereoactivity of more than 800 second of arc. So this patient improved to 6/6 after 7 sittings. The contrast sensitivity also improves from 0.35 to 1.25. And stereoacuity also improves from more than 300 second of arc to 70 second of arc in only 7 sittings. These are my references and acknowledgements. So we need combination of therapies for management of amblyopia. Thank you. Thank you so very much.
Wonderful talk, Dr. Arvind. I would like to ask Dr. Santhan Gopal for his comments. Sir? You are not audible, sir.
So you need to unmute Dr. Gopal.
Can you hear me now?
Yes, sir.
Yeah. No, you're the other person who is using orthoptech, and one has been supplied to LVPA, which has never been used for unknown reasons. But it works good because of the fact that it stimulates the pathways which are already existent in the brain. It's not that these pathways grow; they are existent right from birth, just that they are not utilized. So that's how it works very well. And the stereopsis, in fact, improves very rapidly. Within about a week's time, the stereopsis comes back to normal. The reason for that is that the suppression that happens at the level of 4C beta, whereas the stereopsis happens via the corpus post-corpuscular pathway. That is, the posterior part of the corpus callosum is where the comparison of the two images of the eyes in the brain happens, and that is not suppressed. And therefore, the stereopsis improves rapidly compared to even monocular vision. 618 vision improves to 618. By then, the stereopsis comes to normal, 40 seconds apart. I don't know, Jitendra has had any experience with orthoptic which he has bought. But there are right now about 100 people who have bought all over India. And they are not publishing papers, unfortunately for me, but they are all quite happy with it, using it. So LV Prasad can start using Manju.
Yes,
Dr.
Dr. Gopal.
That has been supplied
Yes.
free of charges to you. Still, it's
Yes.
not used.
Yes, yes. Thank you so much, Dr. Gopal, and thank you for the excellent talk on amblyopia. Amblyopia, as we know, it is very challenging, and from patient point of view, it is really rewarding when patients get benefit out of it. Shall we move on to the next speaker?
Just a quick comment on another modality, which is perceptual vision therapy, which has also come up, and it is also quite rewarding. Most of these therapies which have come up are, in fact, they are very similar to what Dr. Gopal has said, that they work from down to up, top to down impulses, and it is basically the orthoptech perceptual although the theory may be different. There's some would be using anaglyphic glasses, others may be using Gabber's patches, and the Occlutab, which we had published our work also, that also uses top to down impulses, because at the end of the day, it is not only the stimulation of eye, but top to down impulses which work. So that has also a very good promising modality and should be used as much as possible. Yeah, I think we can move on to the next speaker.
Sure. So our next speaker is Dr. Reshma Mehta. Dr. Mehta is done her post-graduation and fellowship from Pune and is assistant professor at ARMCH Sholapur. She's also received the award for retinal imaging at the state conference and has extensive experience in strabismus, pediatric ophthalmology, and in undergraduate and postgraduate teaching. So welcome, Dr. Reshma Mehta, and over to you. Can you please share your screen?
Yes, thank you, Dr. Manju, for a nice introduction. I thank GuruSangam faculty for giving me an opportunity in this prestigious forum. I thank Dr. Santosh Unawar, Dr. Harbansh Lal sir, for giving me this opportunity to teach on this difficult topic of nystagmus. I hope the PGs will benefit with this, and I will keep it very, very simple. Can you see my slides? Are the slides visible?
Yes, please go ahead.
So we are going to talk about nystagmus, the terminology, the description of nystagmus, how to examine a patient with nystagmus from early childhood, how to investigate, and the management of nystagmus. So coming to the definition, it is involuntary to and fro rhythmic repetitive eye movements. If it is not rhythmic and not repetitive, the eye movements, it is not nystagmus, but it is nystagmoid movements. It can be opsoclonus or oscillopsia. So it has to be involuntary, to and fro, rhythmic and repetitive to call it nystagmus. Coming to the classification, it is sensory and motor. This classification is the old type. We presume that every nystagmus has a sensory cause. And it is referred as the eyes have impaired vision and hence ability to sense the vision is poor in sensory classification of nystagmus. For motor nystagmus, the brain has impaired motor control of eye steadiness. But this classification is not used now. Nowadays, we have different terminology for nystagmus. We will come to it later. Coming to the description of nystagmus, it can be horizontal, vertical, torsional. Each of this is pendular or jerk. It can be horizontal pendular or horizontal jerk, vertical pendular or vertical jerk, and torsional pendular or torsional jerk. Pendular, to describe, it has two phases. It has the same velocity on each side. Jerk has one fast phase and the other is the slow phase. So we have described nystagmus first as horizontal, vertical, torsional, then pendular jerk. Now coming to frequency of nystagmus, that is number of beats per second, and amplitude of nystagmus, that is how large is the excursion. So this is a graphic recording of nystagmus which shows the periodic alternating nystagmus, the low amplitude with the arrows far apart, upbeat nystagmus with the arrows showing up, low frequency, right jerk, high frequency with multiple arrows, rotatory, the null zone, and the pendular alternating nystagmus. So the null zone is where the nystagmus is the least and the vision is better. Frequency amplitude is the least. There is a longest foveation time and hence the visual acuity is best. This null zone is used for, we have to find out the null zone of the patient in nystagmus for surgical approach. Then coming to the next classification is manifest and latent. Manifest nystagmus is seen all the time and latent nystagmus is seen only when the fusion is disrupted, that is one eye is covered or in presence of squint. So coming to manifest nystagmus, it has a jerk, there is a slow and a fast phase. The slow phase is the abnormal component which takes fovea of the object of regard. The fast phase is the corrective phase. Nystagmus is conventionally described according to the fast phase. So it will be right beating or left beating according to the fast phase, which direction it is. So nystagmus is conventionally described according to the fast phase, but the slow phase is the abnormal component. Then we record the nystagmus with the help of the electronystagmograph. This is shown here, the pendular which has a equal wave velocity and the jerk which has a slow and a fast phase. Then we have the manifest latent nystagmus. That is now, as I have already told you about the classification, initially it was classified as sensory and motor, that all the nystagmus, every nystagmus will have a sensory cause. And then it was classified as manifest and latent. But now nystagmus has a new name, that is FMNS, that is fusion maldevelopment nystagmus syndrome. As the name suggests, this nystagmus is because of the maldevelopment of fusion. Now, when you have both the eyes open, the nystagmus will be there or absent, and latency will be superimposed on the manifest. And I will show you a video that shows the fast phase is away from the occluded eye. So nowadays, nystagmus is termed as FMNS, that is fusion maldevelopment nystagmus syndrome. And as the name suggests, nystagmus is because of the maldevelopment of fusion. So classification, nobody is using sensory motor latent manifest. Everybody is talking only about FMNS. And in FMNS, they also talk about NAFEX, that is the visual acuity, which is expanded in nystagmus. So it is the expanded nystagmus visual acuity, which is the null zone and which is important in surgeries. Then we have the infantile congenital nystagmus. This has a slow phase. The null zone is minimal. Site of lesion is not known. Etiology is uncertain, and head turn or face turn and head tilt will be there. So this is a video of latent nystagmus.
This is another form of congenital nystagmus. However, in forward gaze,
now we've covered one eye. You can see the nystagmus in the uncovered eye. As soon as you uncover the other eye, you can see esotropia and DVD.
Here, the right eye is occluded. The jerks are away from the occluded eye.
So again, we will see as soon as we cover, there is nystagmus in the uncovered eye.
Which is occluded.
When we remove the cover, you can see DVD and esotropia. And the fast phase is away from the occluded eye. This video is there in the net. Now, after classification, now we have described nystagmus definition. We have described how to describe the nystagmus. We have learned how to describe the nystagmus. We have learned the classification. Now we come to a patient where we ask history. So what all points do we ask in history is when was the nystagmus first noted, whether it was at birth, 3 months or 6 months or later. If it is later in adulthood, whether it is congenital nystagmus or acquired nystagmus. Now, how is the vision of the child? Is there any problem in school? He is not able to read the blackboard, or during watching television, he goes very close to the television and holds books very, very close. Is there any day-night difference in vision? Difficulty in dim illumination suggests of rod cone dystrophy and retinitis pigmentosa. And if there is photophobia, history of photophobia, it is suggestive of achromatopsia and cone dystrophy. We also ask history of any oscillopsia, which is very suggestive of acquired nystagmus. We are not covering acquired nystagmus. We are discussing infantile nystagmus syndrome here. Then history, we ask for what reduces the nystagmus, that is, if convergence reduces the nystagmus, or sleep, during sleep, any strange behavior like head posture, head nodding, which is suggestive of spasmus mutans. We look for the general health of the child, any neurological history, developmental delay. Look for the oculodigital signs, that is child poking the eye, severe vision loss due to severe retinal disease, that is Leber's congenital amaurosis or retinopathy of prematurity, advanced, that is stage 5. Then birth history, we should ask for prematurity, birth weight, STOMI, perinatal course, NICU, surfactant, blood transfusion. Then we should ask for the milestones if they are delayed. There is no neck holding. The child is not able to sit or crawl. You'll ask for the family history, because in oculocutaneous albinism, where they also ask for history of sunburns, oculocutaneous albinism, there is nystagmus. And all this, we will be able to identify whether there is optic atrophy or there is cerebrovisual impairment, and there is profound vision loss leading to nystagmus. So history is very important to find out what is the cause. Then after taking history, we come to examination. So examination, visual acuity, how to test vision in a child with nystagmus. Do we do monoocular occlusion? If we do not do monoocular occlusion as we do it routinely with a blank, but we use the Spielman occluder, which is translucent, or we do distant occlusion so that the peripheral cues are present and the nystagmus does not increase and vision doesn't drop. or we can use plus 3.5 to 5 diopter of lenses, that is fogging, to record vision. We also check the binocular vision. If the binocular vision is good, it may be good than uniocular vision. And we see the near vision, and if it is good, it is because of convergence, and nystagmus decreases. After vision, we come to the pupils. We check the light reaction. If look for any paradoxical pupillary reflex. It is seen in congenital nystagmus, and the causes can be congenital stationary night blindness, achromatopsia, optic nerve diseases, or retinal dystrophy. What is paradoxical pupils? We expect the pupil to dilate when the light is off and constrict when the light is on. But in this inherited retinal disorder, the opposite is observed. The opposite is observed. So actually, when we are showing the light, the pupil will not constrict but will remain dilated. And the cause of this phenomena is not known. Then we ask the patient to read the Snellen's chart. When the patient is trying to read the Snellen's chart and the smaller optotypes, there is more visual effort and a significant head posture. This head posture is because of the expanded nystagmus acuity function, or it is trying to get the best vision with least nystagmus, where there is frequency of the nystagmus, amplitude of the nystagmus is least, and there is longest foveation time. So this is NAFEX, and we should find out this null zone for surgery, for surgical purposes. So we've done with history, we've done with vision, we've done with the pupils. Now we see the entry segment. Look for cataracts, corneal opacity, coloboma, aniridia, iris transillumination defects. And then the fundus. In the fundus, we look for optic nerve hypoplasia, pallor, coloboma, foveal hypoplasia, bullseye maculopathy, toxoplasma scar, toxoplasmosis scars, and RPE alterations. After examining the posterior segment, we do refraction with homatropine or atropine, depending upon the age of the patient. In high hyperopia, you will get high hyperopia in patients with Leber's congenital amaurosis, and high myopes in retinal dystrophies and congenital stationary night blindness. So giving glasses and giving correction is a must. Now after taking history, vision, anterior segment, posterior segment, and refraction, we've come to investigations. Now, what investigations we will do in a patient with nystagmus? We need to do ERG, MRI, and OCT. So in which patients we will do ERG? That is electroretinogram. In patients with infantile congenital nystagmus with poor vision, but there is poor vision, but the optic nerve is normal, fundus is normal. There can be history of photophobia, bilateral high myopia. On examination, there can be paradoxical pupils, ocular digital sign, and retinal dystrophy. So in all these patients, we do ERG is a must. Again, when we are doing ERG, the timing of ERG is also important. That is, ERG is often subnormal in less than 1 year of age. So we have to wait till 1 year and above. Now, when to do MRI? When the ERG is normal, but there is oscillopsia, that is, there is not rhythmic, repetitive to and fro movements, but there are different nystagmoid movements or opsoclonus, and it is not appearing as infantile congenital nystagmus or infantile sensory nystagmus. There is optic nerve pathology, unclear onset. It is not at 3 months, 6 months, or within first year. It is acquired. There is a funny nystagmus like seesaw nystagmus, and there are other neurological signs. These patients, we need to do MRI. And what do we find when we do an MRI? We may find optic nerve hypoplasia, absent septum pellucidum, optic atrophies. There can be a suprasellar tumor and chiasmal lesions. So we have done with the investigations, that is ERG and MRI. We have learned when we have to do ERG and when we have to do MRI. Now we are coming to something called as unilateral nystagmus. This is seen in patients with spasmus nutans. That is, they have very poor vision in one eye, and in chiasmal lesions or the Hellman-Belchowski phenomena, and patients which have unilateral visual loss. These patients will have unilateral nystagmus. So here we have to rule out gliomas or subacute necrotizing encephalopathies. In these patients, you may see seesaw nystagmus or pendular nystagmus. Now coming to, we have described the definition. We have learned about how to describe the nystagmus as horizontal, vertical, pendular. We have seen how to describe the nystagmus, whether it is pendular or jerk, the frequency, amplitude, and the null zone. Then we did the classification, and we know now we discuss about only FMNS, that is fusion maldevelopment nystagmus syndrome. So now, after describing all the nystagmus, we have done with the history, examination. In examination, pupil is very important. Look for the paradoxical pupils. Look for retinal pathologies. Look for optic nerve hypoplasias. And then we decide for surgery or for management. So surgery is done if there is abnormal head posture. If there is coexisting strabismus, there can be esotropia or exotropia. If the eye is continuously moving, leading to very poor vision, these patients we take up for surgery. Now, checklist is like, what all do we check before taking the patient for surgery? Is there is no oscillopsia, there is no opsoclonus, no neurological cause of nystagmus, upbeat nystagmus, downbeat nystagmus, or periodic alternating nystagmus. That is any intracranial cause. We should record the vision in primary position. The abnormal head posture with the goniometer, we have to record it. Any convergence to dampen nystagmus, visual acuity with both eyes open and with fogging. And check vision in the preferred head posture. We have to record that. Now, non-surgical intervention is contact lens. Contact lenses can be given to high hyperopes or high myopes. There is sensory irritation, and hence the nystagmus decreases. Pharmacological intervention is baclofen, 5 to 10 milligram TDS, or botulinum toxin, brinzolamide, that is acetozolamide drug, 1% TDS, that increases the foveation time. But baclofen, memantine, and gabapentin, these can be used. They are indicated in downbeat nystagmus or upbeat nystagmus or acute pendular nystagmus, periodic alternating nystagmus, and infantile congenital nystagmus. But these drugs have side effects like dizziness, incoordination, drowsiness. Hence, they are not very popular. But now, brinzolamide and baclofen are used, and brinzolamide it is helpful in few patients. You may see that there is decrease in nystagmus in few patients, but the cause, how it helps, is not known. Then we have prisms. We can use prisms, that is yoke prisms, by using the apex, keeping prisms with apex towards the head posture in front of the dominant eye, apex in the same direction. It helps in treatment of small head posture to centralize. We do centration of the head posture with the help of yoke prisms, that is incorporated in their glasses. Now, surgical procedures, as we have already seen, the surgical procedure, we have done the checklist, and we have seen the indications why we are doing surgery. It is to reduce the abnormal head posture, to reduce the strabismus which is coexisting, and to decrease the continuous moving of the eyes or improve vision. So how will it help? It will improve visual acuity, it will improve contrast, it will improve the foveation, it transfers the nystagmus null zone to the frontal plane, and it corrects strabismus. After correcting strabismus, again there is restoration of binocular fusion and stereopsis. So the Delozo surgery or the tenotomy, which is done, it is done in patients which have only nystagmus with no null, and in primary position the null is present in primary position, and nystagmus is without any neurological cause. And Delozo operation is tenotomy and reattachment of all the 4 muscles. Recession is done, and it helps the 4 horizontal recti are detached and resutured at the same insertion. So the intensity of nystagmus is reduced, broadening of null zone is present, and there is improvement in vision and 40% increase in NAFX. So this is indicated in patients with nystagmus who have null in primary position and who have nystagmus without any neurological cause. Now, patients who have an abnormal head posture, a head turn or a tilt or a chin elevation or depression, these patients, we do augmented Anderson procedure. This is 9 mm MR recession and 12 to 13 mm LR recession. Now, this helps in correcting the face turn, which is up to 20 degrees, and reduction in amplitude of nystagmus and reduction in frequency of nystagmus. So this is indicated in patients who have moderate face turn, augmented Anderson procedure. And patients with augmented Kestenbaum-Anderson procedure, this is done who have a face turn which is large, which is up to 20 to 60 degrees. So this is augmented Kestenbaum-Anderson procedure. This is again done in patients with infantile nystagmus syndrome who have a moderate face turn. Then you have the oblique or torsional Kestenbaum-Anderson procedure. This is done where your inferior oblique is advanced or recessed and superior oblique fibers tenotomy or advancement, that is the Harada-Ito. This is done for correction of head tilt, and the indication is also for head tilt. So obliques are operated if you have head tilt. And in patients with chin elevation or depression, then those patients myectomy or superior rectus recession. So that will again correct the head posture, which is chin up or down. And the combined squint and nystagmus is those patients which have squint, iso or exo with nystagmus. So there we correct squint and we correct the nystagmus. It will improve the vision and improve the stereopsis and decrease the nystagmus. So I hope this is helpful for the PGs. And to the take-home message is how we describe nystagmus is it can be horizontal, vertical, or torsional. There are two ways we describe it. That is the pendular or the jerk. Then we have the amplitude and the frequency and the null zone, which is important. Then classification is infantile, is sensory and motor, and latent and manifest. But now the classification is FMNS, that is nystagmus is described in form of FMNS, and all the nystagmus is because of sensory cause. You should presume that. Then after describing the nystagmus, we go to history, visual acuity, look for the pupils and look for the light reaction. If there is the paradoxical pupil. In history, ask when we are testing the vision, it is very important to ask whether there is any problem in dim illumination for retinitis pigmentosa or there is any photophobia for congenital stationary night blindness. Look for the fundus to see any optic nerve hypoplasias or retinal dystrophy. And then you can post the patient for ERG or MRI. Look for any neurological symptoms, signs, and then decide to treat first pharmacological, then contact lenses, and then surgical procedures. Thank you.
Okay. Thank you so much, Dr. Mehta. So nystagmus in a sense is a complex topic, and thank you for simplifying it and subdividing it into different stages of evaluation and assessment for all the audience and the delegates who've joined in. So, and also the other thing is whenever we are recording or trying to look for nystagmus is to obtain a long enough video to make sure that there is no change in the head posture, especially in periodic alternating nystagmus, because that is one thing which we wouldn't want to go ahead with surgery. But I'll ask Dr. Santhan Gopal for his inputs as well. Thank you, sir. You need to unmute Dr. Santhan Gopal.
One important feature you need to look for in nystagmus is, does a horizontal nystagmus, when the patient looks up, change its direction? If a horizontal nystagmus, when looking up, becomes vertical, then definitely do an MRI. It is not normal. So any nystagmus which is normal will retain its horizontal direction or its vertical direction in all 9 gazes of direction of position of the eye. But if there is a change in the direction of the nystagmus, with change in the position of gaze, then one has to do an MRI. So it's simple mnemonic to remember. The second thing is the most difficult to decide is nystagmus with squint. See, the procedure when you do for squint can increase nystagmus, and the procedure that you do for nystagmus can increase the squint. So it's very difficult to decide when there is a nystagmus and squint. Sometimes you have to reassess and think for some time before you operate on these patients, and not just do. So sometimes just one squint muscle operation itself can correct both nystagmus and squint. Just like the muscle operation for nystagmus can increase the squint, it can also correct the squint. So these factors have to be written down on a piece of paper. Okay, I'm doing LR recession. If I do LR recession of this side, that may increase the exotropia in this side. So I'm going to do MR resection on the other eye. That will reduce the exotropia. So these calculations have to be done properly on a piece of paper. Even for experience, it becomes very confusing and difficult at times. Jatinder had some thoughts on this.
Yeah, I think it's partly it can be done by finding out which is the dominant eye. If you have the dominant eye, if you know which eye is the dominant eye, and that is one of the reasons why Dr. Manju says that you have to have a couple of videos before you think of operating them, so that you don't miss out on periodic alternating nystagmus. You're sure that they have a specific face turn, and if you have the dominant eye, you have to operate the dominant eye for nystagmus, and whatever strabismus is there, you can operate on the non-dominant eye. That is how I normally manage. I agree that there can be few exceptions, but most of the cases, if you have the dominant eye, you have to operate the dominant eye for the nystagmus. Like if you have a face turn to right, the right eye will be in esotropia and left eye will be in exotropia. So if right eye is the dominant eye, you have to operate it for the face turn. And the non-dominant eye, if there is more exotropia because of this particular surgery, then we have to do more on that particular eye. So that is a good way of doing nystagmus with strabismus. Rishikesh has something.
I have just one question actually regarding the expert panel about their experience with brinzolamide in nystagmus. Can somebody share?
Yeah. So, if Manju has to say something, yes.
No, you go on. So, I personally don't have much of experience with brinzolamide. I would honestly say I tend to sometimes use baclofen more often. But yes, there have been reports as well as I would say a lot of some of the experts who have used it and have mentioned its positive effect in nystagmus. Although we don't know for how long and how much and what happens after stopping the drug.
So I have some experience with brinzolamide. So what I have to say is that, it does not really make a big difference in your clinical outcome. And but it is mainly you have to do a VNG or an ENG to find out the NAFX. And the authors, mainly it is the work of Dellozo and Richard Hurtle, who have worked on brinzolamide. In my own clinic, I think around 25% of patients do say that they are better after using the drops. But you have to wait for 3 weeks and you have to give it to the patient, because I don't have a VNG. So it is very difficult for me to quantify it with the help of VNG and NAFX. But clinically also, you don't see much of a difference. It's just that the patient says that he is better. Probably some of them may be responding because of placebo, and some may be having some benefit.
Do you think it helps with the proprioception? Probably that is also last
that is the theory.
suggested theory.
So, so the theory is that the carbonic anhydrase inhibitors help in the proprioceptive receptors, which are there at the peripheral proprioceptive receptors at the lateral rectus and medial rectus. And by changing the calcium channels, they have a better proprioception, and that improves the NAFX. So that is the theory of it. But I think there was a good there was a best paper by Mihir in Agra conference. I think AIOS Agra 2014. He had a paper on brinzolamide eye drops. The only Indian work which has been printed, not really published, but which is in print.
We can move on.
Orthoptic treatment works very well in nystagmus because of its action on the proprioception mechanism of the muscles which are not operated. It works very well at the level of parietal cortex, where it works, where there is exactly a sensory motor integration center is in parietal cortex. And because of the stimulation of the attention center in the parietal cortex, the orthoptic reduces the frequency of nystagmus and improves the head nodding associated with it. Same way as the acupuncture works, by keep putting a pin on the shoulder, somewhere here in the neck, it reduces, supposed to reduce the nystagmus because it works along the trigeminal nerve and therefore reduces the nystagmus.
Thank you. Thank you, Dr. Gopal. Dr. Jaitan, we will move on to the next.
Yeah, I think we can move on to the next speaker, who is an esteemed pediatric ophthalmologist. Dr. Rishikesh is from Nagpur. He is the consultant at Avdut Netralaya, having done his fellowship from Shankar Netralaya. And he is also academic consultant at Suraj Eye Institute and PG Center. So he will be speaking on management of acquired esotropia. Over to you, Doctor Sir.
Yeah, I'm audible, right?
Yes, yes. You can share your presentation.
I'm not getting the share screen option right now. Yeah, it is there. So at the outset, I would like to thank AIOS for this wonderful opportunity, Dr. Harbans Lal sir and Dr. Santosh Anawar sir, for making me a part of this esteemed meeting on pediatric ophthalmology. I'm sorry. Yeah. So the topic which I will be presenting is acquired esotropia, diagnosis and management. My slides are visible, right?
Yes, yes, please go ahead.
Okay, right. So I will restrict this presentation for the postgraduates primarily because that is the aim of this particular event. So esotropia, I don't have any financial interest about some products which might come in this presentation. So esotropia can be either congenital or it can be acquired. Basically, any esotropia which is not present at birth or and it happens to occur 6 months down the line is considered an acquired esotropia, though this 6 months is not foolproof because there are few cases of accommodative esotropia which can present earlier also. So congenital esotropia is usually an infantile esotropia or congenital sixth nerve palsy. The acquired types can be like any other strabismus entity, can be comitant or it can be incomitant. Coming to acquired esotropia, it can be classified as comitant and incomitant. The comitant variety includes accommodative and non-accommodative. The accommodative type can be fully accommodative, partially accommodative, or it can be with a high AC by A ratio. Non-accommodative type can be sensory esotropia, a cyclic esotropia, or a acute acquired comitant esotropia. Coming to incomitant type, as everybody is aware, the most common paralytic variety of esotropia is sixth nerve palsy. Sometimes a bilateral fourth nerve palsy can present with a V pattern, especially in down gaze. Due to paucity of time, I will not include fourth nerve for further discussion, but sixth nerve will be presented later on. The restrictive strabismus or restrictive esotropia can be thyroid eye disease, though esotropia is or the medial rectus is less likely to be involved. More common it is the inferior rectus. medial rectus is the second most common, or it can be because of cysticercosis, myositis. Some clinicians consider esotropia with high myopia as a restrictive variety, but there is another school of thought which consider it as a acute comitant esotropia. So I will start with one case of 18-year-old girl. I actually wanted to share this case just to present the evaluation part of esotropia. So 18-year-old female, she presented to me with history of esotropia since last around 10 years. Whenever it's an acquired esotropia, few things which you need to ask the patient is whether there is any binocular diplopia, whether there is any change of squint over time, that is, it can be intermittent, which might become constant later on, or if there is any change of squint with time. If there is any history of trauma, a focal neurological deficit, or a headache, which indicates some neurological event, or a raised intracranial pressure, especially in females, benign intracranial hypertension can present with a sixth nerve pulsing. So in examination part, like in all cases, we check for the binocular, best corrected visual acuity, which was 6/6 in her case. For any case of squint, we evaluate before evaluation, we check for any abnormal head posture, we check for facial asymmetry, or any lid abnormality like ptosis or a lid retraction. Then do a refraction, a dilated refraction, a cycloplegic refraction. In her case, she had a mild hyperopia in the left eye. Anterior segment was normal. Whenever you are evaluating for fundus, look for any fundal torsion, which can indicate, usually we are seeing for any inferior oblique overaction in this case. So this was the examination part, the motor evaluation. Now I'm doing a cover and uncover test. This is a Spielman occluder, which helps in checking for the deviation under cover. So primarily she was fixing with the right eye. So we are seeing whether the left eye is able to take fixation or not. But under binocular circumstances, definitely she is using her right eye for fixation. So we will label it as a left esotropia. Had she been able to maintain her fixation with the left eye, even after a blink, then we can call it as a alternate esotropia. And now I am doing a alternate cover test, which is for esophoria and tropia, both the latent and the manifest component. As it is a esotropia, when you are doing an alternate prism cover test, 2-3 things. First, you place the prism in front of the dominant eye, in which case, in her case, it is the right eye, and apex towards deviation. So it will be the base out prism in the right eye. And I usually use the loose prisms, not the prism bar, just as a habit. And then we do an alternate prism cover test to see for whether you are able to neutralize the esotropia. Now I'm trying to increase the power to get the neutralization. Always correct the head posture when you are doing this test before, and also ask the patient to fixate with the eye which is under prism, because sometimes the patient may not be able to fixing because of the higher power of the prism, or because the prism the vision might be blurred. So like right now she's not fixing, so I'm getting a very false high reading of the esotropia. So always ask the patient whether she is able to fix at the distance accommodative target before you go ahead with recording your finding. And finally, I get a neutralization point just to show how to hold the prism in front of the left eye if you are a right-handed person. And I'll recommend all the postgraduates to be in a habit of doing the prism, the cover test, alternate cover test, and alternate prism cover test, so that you become fluent at the end of your examination, because the examiner will be easily able to point out if you are not good at it, and do it for distance as well as for near. So this is the ocular movement of her, this I'm right now checking for the superior rectus in the right eye and the inferior oblique in the left eye. Primarily inferior oblique overaction is what I'm trying to check. In up gaze, we are actually checking whether the eye is going into any divergence or any pattern can be elicited, though pattern can be actually measured using a prism. Right now it is for the left eye, the inferior, the inferior oblique in the right eye is what I was checking, and look for any deviation. Now she has a bit of convergence in down gaze, and look for any superior oblique underaction. She has a superior oblique underaction in the right eye, as well as in the left eye also. So these are some basic findings which you can use for your further evaluation and management later. So coming to a case of, coming to accommodative esotropia, which is one of the commonest type of acquired esotropia. The underlying pathology is a hyperopia, which can produce a retinal blur. Now, the retinal blur can have two consequences. Either the patient will use his effort of accommodation to see the picture clearly, but it will also induce accommodative convergence. If this accommodative convergence is balanced out by fusional divergence, then the patient might have a esophoria or a orthophoria. But if the fusional divergence is less, this is all hypothesis. If the fusional divergence is less and it is not able to compensate for accommodative convergence, the patient will develop a esotropia. So not all patients who have a uncorrected hyperopia tend to have esotropia. If the patient continues to, doesn't put an effort of accommodation, he will have a blurred image with orthophoria and he might land up in amblyopia. This is a slightly dangerous condition, as already mentioned by Dr. Arvind in his presentation on amblyopia, because if the patient in our country, if the child doesn't have a squint, they hardly come to a ophthalmologist, forget a pediatric ophthalmologist, for further evaluation. So whenever you get a patient of esotropia, we do a atropine refraction. First, we use 1% atropine eye ointment for 3 days, rise grain size in both eyes, and on the 4th day we can do a refraction and give the full hyperopic correction. We call it as trial of glasses. So we evaluate the patient 1 month after, because atropine usually has an effect of around 21 days. So after 1 month, if the child is, the esotropia is completely gone for distance and near, we label it as a refractive accommodative esotropia. If the patient sees ortho for distance, but there is an ESO for near, we try a +3 diopter glass and check for any change in deviation. If the near deviation gets corrected, we can label it as a non-refractive accommodative esotropia. But in some cases, the near deviation still persists with the +3 diopter glasses, which in case we call it as a non-accommodative convergence excess. If the child is not, it gets only partially corrected with the glasses, we label it as a partially accommodative esotropia. Though we label one child as a complete accommodative esotropia, they might change with time. So we need to follow them up. Fully accommodative esotropia may become partially accommodative later on. So refractive accommodative esotropia usually presents in 2 to 5 years of age, though it can present earlier. There are reports of as early as 4 months also. So for all cases of esotropia, we always give trial of glasses before we decide about any further management. So the most common question which parents tend to ask is what happens to the esotropia later on. Usually it goes into the second decade of life also. Fortunately, because the child is, gets correction with the glasses, binocular single vision is usually good in these cases. So we can have a clue about whether your glasses are able to correct the squint or not. With this, she is wearing +6 diopter glasses, and you can very well see this is the that your glasses will be able to correct her esotropia or not. Coming to the refractive accommodative esotropia, usually it needs glasses, and we tend to follow up the patient every 6 monthly to check for the compliance, whether there is any change of glasses and also whether there is any change of squint. So coming to non-refractive accommodative esotropia, where the patient tends to have ESO more for near than for distance. All other patient profile is the same as the previous variety. Only thing is that he or she has more ESO for near, which can be explained by AC by A ratio. Now, what is this AC by A ratio? Accommodation, it is called accommodative convergence by accommodation ratio. For every 1 diopter change of accommodation, how much prism diopter change is the convergence? Usually it is around 3 to 5 prism diopters per diopter of the change in the accommodation. It can be measured by gradient or heterophoria method. A more practical approach which we usually use is checking the deviation for near minus, that is around 25 to 30 centimeters, and then checking the deviation for distance accommodative target, and we divide it by 3. So the value should be less than 5. if it is more than 5, we label it as a high AC by ratio. For all practical purposes, if the deviation for near and deviation for distance, if it is more than 10 prism diopters, it usually falls into the high AC by ratio category. So this is one patient who he developed esotropia at 2 years of age. He was partially corrected and he had, more deviation for near. So we gave him executive bifocals, and later on he went into exotropia, for which we had to switch over back to the regular plus glasses. So the patient, the behavior of this squint can change with time also. So coming to non-refractive accommodative esotropia, the management is usually the bifocals. Now the bifocals need to be executive bifocals, or basically they should be bisecting the pupil. So this will not work, the first photo, but second is what we are expecting. Because these glasses are heavier, we need to follow this patient every 3 monthly to check whether it has, the fitting is proper or not. The pharmacological treatment can be phospholine iodide. This can come as a MCQ if that happens to be in your postgraduate exam. Surgically, if it is not getting corrected with any kind of glasses, then surgery can be contemplated for these cases also. Surgery usually is considered if it's a very large esotropia for near and or AC by ratio exceeding 8, and patient is refusing bifocal, or if the bifocals are not working. In these cases, bimedial recession or FADN. FADN is basically retroequatorial myopexy of the medial rectus can be tried. Coming to another variety, which is which is also common type of acquired esotropia, is acute comitant esotropia. We call it as AACE. It has been described as 3 types. The one is for type 1 is associated with anisohyperopic amblyopia with patching and with a sudden onset of esotropia. The second variety is what we called it as the Franchetti type. It is the commonest. It presents with a sudden onset esotropia, usually in first or second decade of life, and it is doesn't have any refractive error or any neurological problem. So we need to rule out other causes of esotropia before labeling it as an acute comitant esotropia. Type 3, as I mentioned previously, few clinicians consider it as a restrictive variety, but few clinicians associate it as a type of acute comitant esotropia as well. So usually acute acquired comitant esotropia will need surgery, and the surgical results and alignment results are good. Stereopsis depends upon what stage and age we are operating in these cases. One new type of AAC which has come since the COVID is excessive use of screen or excessive use of mobile has also induced acute comitant esotropia. There are literature for that, and even I have seen one patient like that. So the treatment of choice for these cases is either a bimedial recession or a unilateral recess resect. I'm just sharing a video of a unilateral recess resect in one of these cases whom we operated, just to understand how the how the recession is done. Recession is basically a weakening procedure. So we need to pass the 6-0 vicryl suture close to the insertion of the muscle. This is the right eye I am operating, and then we disinsert the muscle, taking care that the sutures are not involved in the dissection, and then at the desired extent, we measure the with a caliper on the sclera and pass the suture superficially through the sclera. So this is the recession part. This is the resection of the lateral rectus in the same eye. Nowadays, resection or plication is being used. Plication is basically double breasting of the muscle, where we don't need to cut any muscle tissue as such, but this is a resection which I'm doing. So we mark the measurement on the muscle directly and pass the sutures, and then we cut the muscle and disinsert it, and then pass the sutures partially through the sclera as well as the muscle stump, and bring the muscle stump close to the original insertion of the muscle. So it is tightening of the, or strengthening procedure. So I will share one case of a 24-year-old female who presented with sudden onset diplopia after recovery from a hemorrhagic encephalitis. She had a horizontal diplopia. So whenever a patient presents with diplopia, we need to ask whether it is binocular or uniocular, whether it is horizontal, vertical, or torsional. In her case, it was present in all positions of gaze. And also she did not have an abnormal head posture. Esotropia is quite obvious. There is no doubt about it. And she is using her right eye more often than the left eye. and the prism cover test. This part I have already covered. But she had around 30 prism diopters in all positions of gaze. So there was no concomitance as such. And the ocular movement shows that this is a comitant esotropia, though her saccades are slow, but the movement is full, and she has an end gaze nystagmus. So what I wanted to share is that a patient can have a comitant esotropia after a neurological episode also. So the other rare causes of esotropia, which I will not be covering due to paucity of time, is cyclic esotropia, which presents with esotropia-free interval after every 12 to 24 hours. Patient usually doesn't have diplopia in these cases, but good stereopsis. If the patient has unilocular loss of vision, he might develop a sensory esotropia, usually in younger age group. Consecutive esotropia is because of undercorrection of ESO or overcorrection of exosurgery and will need a revision. And microtropia, some clinicians label it as a esotropia. This has already been covered very nicely. Coming to the concomitant variety, the most common concomitant acquired esotropia is the sixth nerve palsy, which presents with a sudden onset diplopia. Usually it is uncrossed, as has already been discussed. In younger age group, we need to find out whether there is any head injury, or another important cause is benign intracranial hypertension. In elderly age group, diabetes or systemic hypertension or ischemic cause is more commonly involved. The patient usually turns the face on the side of the squint. I just wanted to share one case of a 56-year-old male who had history of hypertension. He had a horizontal uncrossed binocular diplopia and a face turn on the left side, which I think is quite obvious. The more important thing is he had vision which was lesser in the right eye. So 6/12 vision in the right eye because of a early senile cataract there. So under binocular circumstances, he was using his left eye for fixation. So whatever binocular circumstances you get, the squint becomes a secondary deviation actually. Primary deviation is when the normal eye is taking fixation. In his case, it will be the right eye. And if it is the left eye which is taking up fixation, it will be the secondary deviation. Don't use a torch when you are doing ocular motility. So I just wanted to share that. But you can definitely see that there is abduction limitation in the left eye, which goes with the diagnosis of a sixth nerve palsy in the left eye. Always when you get a patient of a sixth nerve palsy, like in this case, she has a left-sided sixth nerve palsy, you do a complete eye evaluation because fundus might present something like this. This is a papilla edema or a disc edema, but don't just stop here and label her as a benign intracranial hypertension. Do imaging or refer her to a neurologist to do that because sometimes you might get surprises like this. A CP angle tumor producing the sixth nerve palsy. I think AIOS ARC has already covered Hess charting, which is a topic in itself. But if this, Hess chart comes as a spotter for the postgraduates, remember that the field with the eye with a smaller field is the paretic eye. In his case, it is the left eye. So check for which eye is underacting, which muscle is underacting. In his case, it is the left eye, lateral rectus. His charting will not only help in diagnosing the paretic squint, but also for spread of comitance, whether there is overaction of the ipsilateral antagonist or there will be overaction of the contralateral agonist, or there will be suppression or less action of the other muscle on the contralateral side. So that decides with how old this paresis is. So sharing one patient who present with a sixth nerve palsy in the right eye and a seventh nerve palsy in the left eye. You can see the secondary deviation when his right eye is taking up fixation. This is secondary deviation, and he's not able to close his eye completely in the left eye, the left side. This was following a head injury, and this is after 1 week, there was some amount of improvement in the strabismus, but he still complained of diplopia. You can see that there is a limitation of movement in the right eye. So when it comes to the treatment part of a sixth nerve palsy, it can be either you can just wait and watch. But if patient wants early relief from diplopia, we have two options. One is chemodenervation, use of botulinum toxin. We don't inject more than 3 to 5 units of botulinum toxin. Basically, the concept is that we paralyze the ipsilateral medial rectus so as to as a measure for the lateral rectus palsy. And botulinum toxin, it inhibits the release of acetylcholine at the neuromuscular junction. So there are two ways of giving botulinum toxin, either using a superior rectus forceps, as in this case, you can use the superior rectus forceps. Medial rectus is closer to the limbus than the superior rectus, so it's not that difficult. But ensure that you pull the muscle above the globe, and with bevel down, you inject into the belly of the muscle. Okay, that is the main thing. Or you can do it under visualization. You don't need to dissect this much when you are doing botulinum, just giving botulinum toxin. This I had done along with the recession of the medial rectus. That's why. So these are two methods. One method also described is electromyography, which is not very commonly used nowadays. The second is prisms. Either you can use prisms directly into the glasses with the base towards the direction of the face turn. But they cannot correct for more than 15 to 20 prism diopters divided into the two eyes. So for larger angles, Fresnel prisms can be used. These are a bit expensive, but they are like stickers which can be placed from inside of the glass frame. Surgery is considered if the esotropia is stable for more than 3 months. Botulinum toxin helps in not only in relieving the diplopia, but also it prevents the contracture of the ipsilateral medial rectus. So the chances of surgical success are much more, or surgery becomes much more predictable after that. So in this case, which I had previously shared, we ultimately, even the botulinum toxin, the third option was surgery. So we did a medial rectus recession in the right eye. In his case, we found first you have to do the force duction test and check for the tightness of the medial rectus, which wasn't that tight. So we did it according to the usual algorithms which we use for a medial rectus recession. And the post surgery, he had improvement in diplopia and also the ocular movement. Ultimately, I mean, if the outcome is good, perhaps your decision making was right. So with this, I would like to conclude that acquired esotropia is an important squint entity in clinical practice. Meticulous clinical evaluation is must for diagnosis of this variety, and correct glasses, surgical planning, and follow-up gives excellent cosmetic and binocular results or stereopsis results. Thank you. Thank you once again, AIOS, for this opportunity.
I think it was a very comprehensive, wonderful talk on acquired esotropia. Most of the things were covered. I have some questions, and then I can ask other panelists to ask. I just wanted to know how frequently you give Botox, and how many patients would not need surgery if given Botox very early in presentation?
I give. Can I answer this?
Yes.
Okay. I usually give the option of botulinum toxin. Botox. Botox is actually a trade name, so I use botulinum toxin. So usually for all cases of 6-nerve palsy, because that is the commonest variety of operatic squint where botulinum toxin can be given. But many of the patients, they are more inclined for early relief from the double vision. So almost 30 to 40% are able, even in ischemic cases also, I have given botulinum toxin. As far as surgical thing is concerned, usually ischemic cases don't need any surgery. In this case, the child which I showed, those who have some neurological cause or trauma, they might need surgery or prisms in the long run.
So, Jitendra, can I just add? So, with regards to Botox, I think it also depends on the time of presentation. Many times in these cases where there are children who have got acquired esotropia, if they present later, that is after 6-9 months, then it's better to go ahead straight away with surgery than think of Botox. Of course, doing an MRI, ruling out any R0 carry malformation and all those things after it's done. If they do present in the really acute and immediate period, then yes, Botox is a more viable option, I would think.
I used to give Botox Yeah, I used to give Botox a lot in during my UK days because it was free. Patient never paid for anything, the treatment. So it was not an issue at all. So I used to use even in comitant esotropias, I used to use Botox.
Mhm.
But then what I realized is that although I used to think that the nerves regrow and the tropia comes back, I have realized that if you after you have given 2 injections, the third injection can be deferred for almost up to 1 year for some unknown reason. You don't whether the nerves regenerate fully and therefore the esotropia is reduced. I can't put my fingers on it. But what I think nowadays I am doing is giving orthoptic treatment. With that, the amount of deviation for sixth nerve, which has been there for a long standing, comes down from 30 prisms to about 15 prisms. Then you need to operate only on one muscle. So that's what I'm doing nowadays. All that pulling the muscle through somewhere else and pushing it through somewhere else, I don't do it at all because it's not needed. The esotropia is never greater than 15 prisms to 20 prisms after orthoptic treatment. But I can't tell you why it helps because the final common pathway is through sixth nerve, and if the sixth nerve is blocked, then how will it improve the deviation? I'm still not able to explain. But the only thing I can tell you is probably through the parietal mechanism it helps, not through necessarily through the sensory mechanism or through the nerves, but it helps through the integrator, motor integrator, which is there in the parietal lobe. Through that, it helps and reduces the amount of deviation. Botox can be used only after 6 weeks. In the first 6 weeks, if it doesn't improve, it's unlikely that it will improve. Most six nerves improve within 6 weeks. That's what my mnemonic. 6 nerves, 6 weeks. Third nerve, don't give any time because third nerve needs to be investigated rapidly. Sixth nerve, you can wait to investigate. Only when it doesn't reduce in 6 weeks, you start investigating. MRI and all those things you do later, not immediately.
Thank you so much. Any other comments, Dr. Jitendra? Should we move on to the next?
We should move on to the next.
Yeah, sure. Thank you. So our next speaker is Dr. Pradeep Kumar Saraf. I actually don't have the introduction slide, but Dr. Saraf is a professor at the Department of Ophthalmology at Vivekananda Institute of Medical Sciences in Kolkata. So he will be very much there for AIOC Calcutta. We can all meet him in person. And maybe with your own introduction slide, you can just tell us a bit more about yourself. Dr. Saraf, over to you. So we can see your slides. Can we go to slideshow mode, please? Thank you.
You have to unmute.
You need to unmute, Dr. Saraf.
Doctor, please unmute yourself before you start.
Yeah.
We'll start from the beginning now, please.
Yeah. I would like to laud All India Ophthalmic Society to take this initiative for teachers to educate, elevate, and excel in teaching. I would like to thank Dr. Harbans Lal, Dr. Gopal, and Dr. Santosh and team to give me opportunity to speak on IOL selection. My talk on GuruSangam is dedicated to my Guru, Dr. S.S. Badrinath. After doing my fellowship from Shankar Netralaya in 1985, I started practice in Calcutta. And I was professor in Vivekananda Institute of Medical Sciences, and I'm doing my private practice also. Selection of IOL is very historic thing. First, we must understand what is the history of IOL and how we developed the IOLs. Initially, we were happy with intracapsular cataract surgery and we were giving aphakic glasses. But the aphakic glasses had the problems, cosmetic problems. Eyes appeared magnified, glasses were heavy. It had visual problems because of magnification by 30%. This magnification led to altered depth of perception, so walking and climbing steps was difficult. There was difficulty with hand and eye coordination, and there was restricted peripheral visual field due to small lens size and roving ring scotoma because of unreflected area outside the field of aphakic spectacle lenses. In monocular aphakia, the loss of binocular vision was a big problem in the aphakic patients. With advent of intraocular lens in 1949 by Harold Ridley, reducing problem of aphakic glasses, with development of phacoemulsification, reducing unpredictable astigmatism post-operatively, associated with sutures in extracapsular cataract surgery, post-operative refractive error is now predictable. We have come to a stage where we can give better vision to patients by selecting proper IOL, and cataract surgery is now a refractive surgery. To begin with, we had anterior chamber and iris fixated IOLs. Complications of these IOLs were related to proximity of structures to which the lens is placed. The anterior chamber lenses were placed in the angle, so there was increased chances of damage to angles and iris, leading to chronic inflammation, glaucoma, and uveitis glaucoma hyphema syndrome. It was also associated with corneal endothelial damage and corneal decompensation. These problems has been reduced by improved quality of IOL. Iris fixated lenses cause corneal endothelial damage, iris chafing, pupillary distortion, more inflammation and CME, and pure pupillary dilatation in iris fixated IOLs. Further, these are the not physiological site for IOL. The IOL lens is behind the iris. To avoid these complications, we started doing extracapsular cataract surgery implantation and posterior chamber implant. Extracapsular cataract surgery also reduces the risk of retinal detachment and CME associated with intracapsular cataract surgery. Initially, we used to use rigid PMA lenses with extracapsular surgery. But there was unpredictable astigmatism and post-operative refractive errors due to sutures. With advent of phacoemulsification and foldable IOLs, astigmatism is reduced. Post-operative astigmatism has been predictable as calculated by SIA calculator by Warren Hill, as shown here. Here you can put the data of your 20-30 cases and you get the SIA, which you can use to get the better result of the surgery. IOLs are now available to correct most of refractive errors and give post-operative near zero refractive error. So we call cataract surgery a refractive cataract surgery. Now selection of IOL depends on a lot of material things, lens materials, designs, and what refractive error you want to correct. Lens material, we have PMMA lenses, silicone lenses, and acrylic lenses, which are again hydrophobic and hydrophilic. Different lens material may lead to different outcomes after surgery, including different in rates of posterior capsular opacification and different optical aberrations that may occur after surgery. PMMA lenses were the first type of intraocular lenses used after cataract surgery. They are rigid and need larger incisions. They are still used in ECC, SICS, and scleral fixated IOLs. IOL made of silicone and acrylic materials are foldable, so more commonly used. The silicone lenses are slippery. They have lower refractive index than acrylic lenses, so they are thicker. And they need larger incision size of 3.2 millimeter to insert IOL. Silicone IOLs lead to premature, uncontrolled opening of IOL within the anterior chamber, which can make IOL implantation more complex. There is a more PCO rate, higher adherence of bacterial cells, so more chances of endophthalmitis, and there are higher adherence to silicone oil after vitreous surgeries. It is now rarely used. Acrylic materials have the advantages that they have higher refractive index, so they have thinner optics, so can be inserted through smaller incision of 2.2 millimeter. They unfold slower than silicone lenses, providing greater control during implantation. The hydrophobic lenses, they have an adhesive property that provide rotational stability. They have lower PCO rate, but unfortunately, glistening is more common with hydrophobic lenses, which may lead to reduced contrast sensitivity, visual acuity, and increased light scatter. Hydrophilic lenses, they have more PCO rate, and IOL opacification due to calcium deposit, which can be result from defect in material and changes in aqueous meiosis during intraocular surgery and in patients with conditions and uveitis has been reported. This type of, you may see the opaque lens, which may have to be removed later on. There are various lens designs also, which may provide you better visual results. The square edge lens versus round edge lens, single piece or multi-piece, and optical properties of lenses are also different. Due to sharp edge, a square edge lens prevents lens epithelial cells growth behind the IOL, reducing posterior capsular opacification. IOL are composed of two elements, an optic and haptics. Optics and haptics. Optic is a central area responsible for the refraction, and the haptics are the appendages from the center optic that hold it in the place. In cataract surgery, generally two haptic designs are used, single piece or multi-piece. Single piece is named as both the elements, optic and haptics, are composed of same material, acrylic, silicone, or PMA. But in multi-piece, haptic is made of different materials as polypropylene or PMA. This is what the advantages of three-piece and single-piece IOL. Three-piece are more versatile and can be placed in capsule or in ciliary sulcus in case of posterior capsular ruptures, but it needs larger incisions. Single-piece lens should never be placed in ciliary sulcus. Several issues may arise with placement of this lens design in sulcus ranging from uveitis, glaucoma, hyphema syndrome, and shift of lens with time. Because the lenses are molded and floppier, haptics permit this IOL to more easily inject it to small incision. So it can be inserted through 2.2 millimeter incision also. It is better to avoid these lenses in pseudo-exfoliation and weak zone use, where the chances of capsular phimosis is more. So here you see in the bag implantation, and this is sulcus fixation IOL. Now we see the optical properties. We have spherical aberration correction lenses, chromatic aberration, blue light transmission, and glistening free IOLs. There are spherical lenses and aspherical lenses. Aspherical lenses correct the spherical aberration of the eye, thereby providing crisp and clear vision compared to other IOLs. In spherical IOL, you see the picture is not so clear as in aspheric IOL. Chromatic aberration is common optical problem that occurs when lens is unable to bring all waves of length of color to same focal point. This may negatively impact on visual acuity, contrast sensitivity, and functional vision. Abbe numbers define the chromatic aberration amount. Higher the Abbe number, lesser is the chromatic aberration. It has been hypothesized that age-related macular degeneration may in part be result of cumulative retinal damage caused by phototoxicity from continuous exposure to short wavelength visible light. Blue light filtering lenses may play a role in reducing the incidence or progression of macular degeneration in people after cataract surgery. But this needs to be balanced against the potential loss of contrast sensitivity and decreased color vision under mesopic conditions and the use that the lens may cause. All intraocular lenses in use today are designed to filter out ultraviolet lights. These lenses are colorless and absorb most ultraviolet radiation and small amount of violet light. Blue filtering light, a yellow in color, designed to additionally block short wavelength visible light at blue end of spectrum. Now, we have choice what type of refractive error we want to correct. We have monofocal lenses, we have presbyopic corrected lenses. In monofocal lenses, we have normal monofocal lenses, monofocal plus lenses, presbyopic lenses, bifocal or trifocal lenses, they're called as multifocal lenses, and EDOF lenses. All these lenses are available with toric options to correct astigmatism. Monofocal lenses are designed to provide the best possible vision at one distance. It may be for near, distance, or intermediate, depending on the patient's required. We can also use two IOLs with different powers in two eyes, one for distance, other for near or intermediate, so that patient may get monovision. But the patient will require spectacle to see at whatever distance the lens has not been optimized for. Monofocal plus lens gives functional intermediate vision also, so that has added advantage over monofocal lenses. Presbyopia corrected lenses are designed to improve vision for all ranges and reduces the spectral dependence. It should be avoided in patients with small people, and it needs full astigmatism correction to get the good results. The presbyopic correction lenses may be multifocal lenses. The multifocal lenses are designed with multiple points of focus and therefore improves vision and reduces rates of spectral dependence. They have corrective zones built in lens such as bifocal or trifocal lenses. Nowadays, bifocal multifocal lenses are not available. Most are the trifocal lenses. This allows you to see near, far, and intermediate objects clearly. Multifocal lenses are designed. Multifocal lenses, by definition, separate light into different foci, and this causes dispersion of energy of light entering the eye. This results in change of physiology of vision as the light follows a different focal performance at level of visual axis consecutively at the level of retina. It is necessary to activate a process of neuroadaptation and capability of brain to adopt changes to adjust neurophysiology of changes that are induced in quality of retinal image by dispersion of light. In multifocal lenses, concerns may be associated with a range of optical abnormalities, including glare and halos. Due to splitting of light in different zones, contrast sensitivity is reduced. Multifocal lenses are again refractive and diffractive types. Refractive multifocal lenses, they work by providing angular zones of refractive powers to provide appropriate focus for objects at near distance and near. So here this is far vision, then near, far, and near. Refractive multifocal implants provide adequate intermediate and distance vision, while near vision may not be sufficient or may affect the quality of retinal image, creating distortion. Pupil dependence is variable design depending on the design. It depends on the pupil size. If there is small pupil, the outer ring does not come in the picture and we cannot see clearly. And there is high sensitivity for lens decentration. If the lens is decentered, it may not work properly. Diffractive lenses, this IOL utilizes the principle of diffraction with refraction to create two foci. The basic refractive power is provided by the anti-aspheric surface, and diffractive power comes from multiple groups on the posterior surface. This provides good distance and near vision, but intermediate vision is compromised. It is less pupil size dependent. They are tolerant to decentration. The main disadvantage is 18% loss of light by scattering and diffractive surfaces. The main difference between simultaneously vision with diffractive multifocal lens when compared to their refractive predecessors is that the out-of-focus light in diffractive multifocal lens tend to spread out uniformly over a larger area. Whereas for refractive multifocal lenses, the out-of-focus light is concentrated into rings around the objects. The broader spread of blurred diffractive IOL components make it far less noticeable and easier for visual system to suppress. You should avoid multifocal lenses in glaucoma patients because they already have reduced contrast sensitivity. Patients with retinal pathology, children as in chance of refractive error changes, and capsular phimosis may be there. In dry eye patients, the patient may have problem in tear film, and that may result in unfavorable refractive results and unhappy patients. The EDOF lens have only one corrective zone, but this zone is stretched to allow distance and intermediate vision. The advantage is there is no glare and halos. It is good for drivers and surgeons, but may need glasses for near work. So if you see this chart, these are the previous refractive lenses which are not used. These are current generated refractive lenses. It causes reduced contrast sensitivity, variable outcomes, corneal aspherical, pupil dependence, and spectacle needs variable at distance and near. In refractive lenses, halos and starburst phenomena reduce contrast sensitivity. Neuroadaptation varies, and EDOF lenses, it is not completely spectacle independent. So till now, we don't have the perfect lens to feed all the needs. Multifocal lens is good for near work. Glare and halos are more so avoid in drivers. Can use only in healthy eyes, as loss in contrast sensitivity may cause visual disturbance in patients expected to get poor vision as macular pathology. EDOF lenses may need glasses for near work. As there is no glare and halos, it is good for drivers, and it can be used in compromised eyes with informed consent. To add up, we have toric lenses. The prevalence of corneal astigmatism of more than 1 is 40%, and more than 1.5 is 20%, and more than 2 is 8%, undergoing cataract surgery. In these toric lenses, the cylindrical power is incorporated so patients can have spectacles-free distance vision. How to select our IOL power in toric lenses? Manual K reading is better than automatic refractometer readings. K reading should be checked before putting any drops. And now we have Barrett toric calculator. And toric calculators are also provided by the IOL manufacturers as Alcon, Technis. But the Barrett toric calculator is best to know the IOL. This is the example of a Barrett toric calculator where we put the patient's name, ID, A constant, K readings, axis, axial length, and it gives us the result that you have to use this power of lens, this SN T6 in this patient to get target refraction of 0.14 spherical with 0.25 axis cylinder. So toric lenses are indicated in corneal astigmatism more than one diopter, corneal ectasia with stable and regular astigmatism. Post-keratoplasty and corneal scar patients where the astigmatism is stabilized, we can use it with good prognosis. We should avoid toric lenses in dry eye patients as it may have variable K readings. Progressive corneal pathology. Corneal scars and irregular astigmatism are relative contraindication for placement of toric IOLs. They may not be relieved of astigmatism completely, but the magnitude of astigmatism may be reduced and may be taken up after adequate counseling depending on patient expectation. Again, in patients of retinal pathology and glaucoma where visual outcome is poor, you must explain the patient before implanting these expensive lenses. Where zonulas are poor, as in pseudoexfoliation, marfans, we should avoid toric lenses as there may be rotation of the lenses. Please note, 1 degree of rotation of IOL may cause a reduction in 3.3% of cylindrical power, and 30% rotation will null the effect. We should also avoid toric lenses in poorly dilated people as we may not visualize the axis of the lens. Intraoperative posterior capsular rent is relative contraindication as it may lead to IOL decentration or tilt in postoperative period. And patients with unrealistic visual expectations should not be used toric lenses. We also had accommodative lenses which can correct vision for all distance by dynamic refractive power with contraction and relaxation of ciliary muscles. I don't think it is used nowadays. There are light adjusted lenses also. This newer type of monofocal lens is the lens which can be customized after surgery with light, and we will be able to adjust lens for any leftover refractive error after the eye heals, so that one don't need glasses for distance. So now when we come to selection of the IOS, we have so many things to look after. The optical properties, material, design, where we are going to put the lens, and what refractive errors we want to correct. The shift in need is from vision restoration to vision enhancement. Earlier generation people were satisfied with regular IOL correction because they confined activities. But now, with active lifestyle, people want more and more intermediate vision for computer work, less dependency of glass, playing sports, all these makes up. So now we have to subjectively select the IOL, what is the patient's requirement, and objective, what is the clinical decisions. Subjective criteria is visual requirements, the lifestyle, profession, hobbies. As drivers should avoid multifocal, and if keen, can go to for ED of IOL. We have a questionnaire which we can ask the patients to fill up to understand what they need. Zone 1 is for reading, swing, applying. If the person is working more for the near, if they need more for the shaving, emailing, computer use, cooking. Zone 2, intermediate range, and watching TV, driving, watching movies, distance. So for the distance vision. So by this questionnaire, we can understand what the patient needs. The cost of IOL is also the very important factor. But here I would like to add that if you want to put the multifocal IOL, we can go for the Indian IOL. Multifocal or toric IOL, we can go for the Indian IOL, which are cheaper than the imported IOLs. Second, patient personality plays an important role in preoperative consideration. One should avoid patients with unrealistic expectation and those with overly critical personality who are very apprehensive and whose demand is too much. We should avoid premium lenses. Objective criteria. High astigmatic toric lens is very important. Some patients, when they come to your clinic, they have never used the glasses. In those patients, multifocal lenses will be very good. Avoid multifocal lenses in cases of glaucoma, macular degeneration, and other eye diseases where visual recovery is expected to be poor. Loss of contrast sensitivity further lowers the vision. Pupil reactivity and size in different light environments. A small size of pupil, we should avoid multifocal lenses. Surgical risk as in posterior polar cataract. Suppose if you are doing a posterior polar cataract first eye, you have done the good surgery and you put multifocal lens. But what happens if you get the PC rent in the second eye? So you should avoid this posterior polar cataract. And poor predictable after refractive surgery. Patients who had undergone LASIK or any other refractive surgery, we should avoid multifocal lenses.
Dr. Saraf, are you able to wrap up in the next 1 minute? Thank you.
Accurate biometry is must for presbyopic IOLs. Optical biometry is preferred, but immersion can be used. Avoid applanation biometry. Embrace your patient's need for reduced spectacle dependence. Be judicious. In summary, preoperative combination of proper selection and proper lens selection eventually leads to satisfied patients. Thank you.
Thank you so much. That was a great and extensive talk on all the different IOLs and very informative. Dr. Gopal, anything that you'd like to add to this? Can you unmute, please? Jitendra.
Yourself, sir. We are not able to hear you. Unmute yourself.
Can you hear me now?
Yes.
All I can say is some amount of astigmatism is very essential, which helps your reading vision. Most of my patients, even with monofocal IOL, they are not glass dependent at all because of that 0.75 diopters of astigmatism in whichever axis helps in near vision. So all this is important because the company is driving us and we are driving the patients, and therefore everything is changing from beginning to now. But is it for good? My answer is probably yes. Yes,
So,
Arvind.
yeah, I have few questions. Number one is, at what age in congenital cataract to implant an IOL?
That's a
And
good
how to
question.
do the biometry?
I think age should not be the criteria. The parameters of the eye anatomy should be the criteria. So if the corneal diameter is more than 10.5 or 10.25, I would like to put the IOL. Biometry, you have to induce it under the GA and you have to use handheld keratometer and a scan. So that's pretty. I mean that's the short of it, because I think we are running out of
Short
time.
of time. I agree with Jitendra exactly, and also the axial length. We need to
Yeah.
look at the axial length to make sure it's not
And
a
at what age group we can implant these multifocals?
No, we don't implant multifocal
no
in pediatrics.
multifocals.
At least I don't implant. I'm sorry. I was trying to represent all the pediatric ophthalmologists, but I would restrict it to myself.
Most of them would agree, and I would agree with you as well. Let's move on to the next speaker. Do you want to introduce Dr. Jitendra? We can take questions if we have time at the end.
Yes, I don't see him in the. Is Dr. Manohar here with us? I don't see him in the participants. So Dr. Manohar is, I think we have kept the best for the last, and that is the difficult part, which is refraction made easy by Dr. Manohar. He's a senior professor and HO, head of the department at SP Medical College, Bikaner. So sir has joined. I don't see him in the participants. So
I don't see him at all here.
Yeah, we don't see him.
So we have time on hand to discuss pediatric cataract and biometry if Dr. Honavar agrees.
Is Honavar around?
Yeah, I think maybe we can start some discussion.
Yes, yes.
If at all he joins, we'll have to cut it short, though.
Yes, sir.
Yes.
So at what age, how much reduction in the IOL power in the pediatric age group for the IOL?
I think what we started some work in 2014. There's some wonderful work done from Dr. Abhay Vasavada early in 2003, 2005. Bharti was one of the co-workers in AGO. There is some work where they have, what they have done is they have tried to compare under 1 year, 1 to 3 years, and beyond 3 years. So traditionally, from the Western literature, we know that under 2 years and above 2 years. So these are two separate groups. But Dr. Vasavada, in their article, which was published in 2005, American Journal of Ophthalmology, Feb issue, I think. So that article, they could categorize it in under 1 year, 1 to 3 years. And so what they said was that the maximum axial length elongation or the rate of growth, so RAG was something which they calculated. There was a formula given in the paper. So that was one. Another article is from LVP. Ramesh has done multiple articles are from LV Prasad. One is on under 6 months, and then there is secondary IOL calculations. And in their article, there was SRK2 as IOL power was considered as the best. Under corrections, we did some work and published in 2016, I think. And what we found was that apart from age, axial length is an independent indicator. So, normally we try to undercorrect with the help of age, but we felt that if at 3 years of age, your axial length is 25, these patients would require higher undercorrection compared to children whose age is 4 years and axial length is 20. So that was what was the conclusion of our article. A single pearl here I would like to give is that whenever you want to undercorrect, the amount of undercorrection has to be feeded in the machine as expected error of refraction and not to be deducted directly like 24 minus 4 is 20. So that has to be seen. Dr. Manju, Dr. Rishikesh.
One of the things that has not been taken into consideration in many of the studies is the process of emmetropization can go on for a few years after birth. So if the axial length elongates, in fact, the cornea becomes flatter. Compensate for the elongation of the eye, the cornea becomes flatter, and the elongation is not, and if the cornea becomes more curved, then the axial length elongates. Okay, then there is an issue of refractive error being more. So the process of hematopization has not been fully understood. Even in adults, when we do the LASIK, what we have noticed is there are various types of corneas for different types of refractive errors. The cornea can be highly hyperopic cornea, or cornea can be highly myopic cornea, even though the refractive error does not necessarily correlate with the amount of refractive error. The axial length does not always correlate with the amount of refractive error. For example, I do a lot of LASIK in anisometropia. And when I do in anisometric hyperopia and anisometric myopia, what I have unilateral, what I have noticed is the cornea of the two eyes are more or less similar. Now, how is that possible? In one eye, the cornea is the same as the other eye, which is emmetropic. Whereas this eye, which has a high hyperopic refractive error, the cornea is also like the other eye, normal eye. So where is the problem? The problem is in the process of emmetropization being abnormal. That leads to various types of refractive errors.
Thank you. Thank you, Dr. Gopal. So I don't know how, I hope it answers your question, Dr. Moria. But basically, it's again dependent upon, as we spoke, the axial length, the corneal diameter, the fact whether the child has got a bilateral or unilateral cataract. Because if it is unilateral cataract, you would tend to undercorrect less so as to not have so much of an isometropia. That itself can be another additional confounding factor for amblyopia. So I would change my measurements if it's a unilateral cataract. And again, bilateral cataract, if it warrants a lens, then again, the 7- age of the child can be a rough guideline that you can use if that helps answer your question. Also, I just wanted to ask all of you, actually, which IOLs would you prefer in children, and whether there's any preference with regards to the age group? I mean, maybe we can discuss that as well. We start with...
I normally use hydrophobic lenses. There is no change in preference as per the age. That's the first thing. So
Yeah.
I'm not advertising, but I usually go either with Alcon or with the Johnson & Johnson lenses. These two.
Okay, I mean 3-piece or single piece?
Single piece.
So 3-piece is mainly when I have to do an optic capture.
Or a secondary IOL.
Yeah, or in secondary IOL. So normally 3-piece, I don't do optic capture as routinely, but if there is traumatic cataracts or where I feel that I should be doing optic capture secondary IOL in sulcus, then I use 3-piece. Otherwise, as Rishikesh said, single piece hydrophobic IOL.
Right. Anyone else differs or uses anything?
Yes. So literature says that you must use multi-piece lens. I don't know why. They say that capsular phimosis is more in children. So with single-piece lens, the phimosis will be more than in the multi-piece lens. So what is the opinion of the experts in this?
I haven't really, personally in my experience over these years, I mean, it's not that any study or something of mine, but it's not that I've experienced more of phimosis in a single piece. So single piece, if it is well centered in the bag, I think it works well enough.
I agree.
I think we need a good rhexis that serve the purpose of preventing the
rhexis is more than 4.5 millimeters. It is difficult.
Exactly. Absolutely.
But yeah, I think you can get a phimosis if you do a small rhexis, but I don't know why 3-piece or maybe the 3-piece will be more snugly fit and may prevent phimosis. That could be the way
because
it is.
Children, the capsular fibrosis is more, opacification also more.
The tilt of those haptics.
Maybe.
But yeah, I mean, as long as the single piece is well centered and adequately placed, it should work as well. Anything else that anyone would like to discuss? Maybe one last aspect.
I have one question. I mean, suppose we are planning, the corneal diameter is not adequate in a very small child, say 4 months or 6 months, and we are with a bilateral cataract. So primarily we will have to do a lens aspiration or a lensectomy. So just to avoid a general anesthesia, will you prefer doing a bilateral lensectomy or will do it separately?
That's a really good question. So I've done both. I have done simultaneous cataract surgeries. We used to do it more in Australia. Somehow that was kind of preferred to avoid repetitive general anesthesia. I've done it more in COVID times, I would say, than pre-COVID or post-COVID at LV Prasad. We tend to do more of sequential, so that just to make sure, keep a gap of about 10 days or anywhere between 1 to 2 weeks, and then remove the sutures of the first eye, just make sure everything is okay. But as such, if there is a child who's got high risk for anesthesia, I would personally prefer to do simultaneous cataract surgeries. But anesthesia is the main driving force. It's not as such the eye per se, but it's the anesthesia.
I have done it in some of the cases, like I've done around 3 cases in the entire last 2 decades, but it's mainly the high risk cases, very extremely high risk cases. And when the patient is understanding that, we are taking a risk.
Yeah.
And it is with the patient. We have to tell them that, it is for not giving the anesthesia twice. And if they are ready to give anesthesia twice, we are more than happy to settle into sequential surgeries.
And even if it is done simultaneously, you have to treat each eye as a separate surgery.
Yes.
So again, change the instruments, scrub again, the scrub nurse, the surgeon, have a separate trolley, have a separate set of instruments. It's as if you're doing a second procedure, completely new set of everything. So I guess we can wrap up the session.
I think so.
Yeah, so thank you everyone. It was a wonderful session and it was great participation by everybody. We discussed a wide range of topics, including right from the start, the sensory tests, which are so important in strabismus evaluation, amblyopia, which is another very important topic, and Dr. Gopal's orthoptic, which we will be using more and more. Then Nystagmus, another complex topic, management of acquired esotropia, which is really hot and happening in the digital era. The AIOS selection, which is again, very versatile, and refraction, which perhaps has partly been covered in every aspect. So I'd like to thank the chairman, the moderators, all the speakers for the wonderful session. And I thank you to also spending your time on this festive occasion. And I think this festival has been made really great by the added knowledge that we have been able to impart to all the postgraduates across the country. Special thanks to Dr. Honawar, because he's the driving force behind all this. And I've noted his education and his zeal for education for so many years. So I'm sure with all these ventures, All India Ophthalmic Society will be able to bring out better ophthalmologists within the country. So thank you everyone, and have a good night.
Thank you.
Night.
Yeah, how many attend the talk?
I think we can ask Dr. Honawar and maybe he'll get back to us.
Okay. Right.
Okay, sir. Good night, everyone. Happy
Thank
Lohri, happy Makar
night.
Sankranti.
Thank you.
Good
Thank you.
night.
Thank you.
Good night.
Good night.
Thank
Good
you.
night, and thank you for the
Very educated.
Thank you so much.
Thank you.